Yes, it's showing.
Yeah, perfect.
Ma'am, we are on live, ma'am.
Yeah, okay. A very good evening to one and all of you here, and a very, very warm welcome. And it's a group of very smart young speakers and absolutely vibrant expert panel. So what more can we ask for? So let's keep the 2 hours, ensuing hours absolutely charged with questions and doubts, and even the speakers are allowed to chip in so that there is maximum exchange of information in the next 2 hours. A very warm welcome to our expert panel, Dr. Ramurthy, whom we all know is the chairman of the Eye Foundation Group of Hospitals and past president of AIOS. Very warm welcome to you, Dr. Sonu Goel. He's the director of Anand Eye Hospital and postgraduate institute based at Jaipur, and he's one amazing cataract refractive surgeon, and I know his inputs are going to be invaluable in the next couple of hours. We are truly lucky to have with us Dr. Rishi Swaroop, who's the medical director and senior consultant at Swaroop Eye Center, Hyderabad. Of course, not just a refractive, but a very good cataract and cornea surgeon too. And I look forward to learning a lot from him. We are lucky to have with us Dr. Subhasini Kaliyapperumal, who is a professor from JIPMER Pondicherry, and she's a cataract, refractive, and glaucoma surgeon, and excelling in all of these fields. We have joining us very soon Dr. Shreyash Ramurthy. Has he joined? He would, I think. He's a consultant cataract, cornea, and refractive services from our Eye Foundation Group of Hospitals. We are very lucky to have with us Dr. Vardhaman, and he's traveling on a very special holiday, but he has not let us down this time too. And thank you, Vardhaman, for being with us. We all know he was most vibrant chairman scientific committee of MOSCON, and is also a member scientific committee of AIOS, and of course, an awesome cataract and refractive surgeon. So let's get the best of him in the next 1 hour.
Thank you, ma'am.
So Pooja has a flight to catch, so let's take her on as the first speaker. So Pooja, Dr. Pooja, just a minute, again needs no introduction. She's a consultant, a senior or young consultant, I would rather say young dynamic consultant in cataract, dry eye, and refractive services at Narayan Nethralaya Eye Institute. And she's going to tell us something which is going to get us all anxious that our presentations need to be equally good too. She is going to talk about revolutionizing vision, the peel approach to corneal surgery excellence. So on to you, Pooja.
Thank you, ma'am, and thank you for letting me go first. Thank you, Rushad and Tushar also. So I'm going to be talking about something which is not very new. It has already been performed in multiple other technologies, like Dr. Sri Ganesh sir has done it for Smile. But it's just that whenever a new technology comes in, there is some uniqueness which the technology has, and maybe some modifications on how we approach and the outcome. So it's just a small upgrade with the technology silk what we've been doing. So traditionally, whenever we do a lenticule procedure, we know that we open the anterior and posterior plane. And then once we identified the anterior and posterior plane, we go ahead and the anterior plane first and then the posterior plane. And then we go ahead and remove the lenticule with a lenticule holding forceps. That's how traditionally most of all the most of the refractive surgeons have been doing. What happens is sometimes if the lenticule a little bit, and if you have to struggle a little bit in the lenticule dissection, especially finding the planes because
lot of network issues.
OBL, then hello.
Yeah.
Hello.
Lot of network issues we are having.
I
hope it's clear now. Yeah,
it should not be there now.
Yeah.
So what happens is if you have a straightforward dissection, if you identify the anterior posterior plane and if it's a smooth dissection, day one, the patients have 20/20 wow vision, and you can see here there's not much of activation of keratocytes, and it fairly looks very good. But if you have difficult dissection or a difficulty in identifying the anterior posterior plane, or if you got into a pseudo plane, then day one patients may be 20/20 or 20/40, but they're not so happy with the quality of vision, and that is because of the manipulation. There is a lot of this edema present at the subbasal level or the stromal level, and because of the edema, the quality of the vision is not very good. So now what happens is, we are, of course, as I mentioned, every technology is different. What has Silk done is, Silk, the spot sizing is different. The spot spacing is different, I may say. Between two spots, the difference is 1 micron. So technically, between two spots, there is not much of space. And also the laser pulse is shorter, and it's low energy. So the vision is very good.
Pooja?
Uh, Sorry. Am I audible?
Yeah.
Yeah. Sorry. So in Silk, the spot, there is hardly any distance between two spots. The spots are next to each other, and the spot size is also smaller, and the laser energy delivered is also on the on the lower energy side. So that makes dissection of the anterior and posterior plane quite easy, because technically there are no tissue bridges. So you have to dissect whenever there are tissue bridges, and that's when you have those minimal edema present. But because the spots are next to each other, there are no tissue bridges, and you hardly have to dissect. So, taking a lead from Dr. Shri Ganesh sir, we started doing this technique in Silk. We labeled it as pressure exerted extraction of the lenticule, where we just do something like a rexis. We just identify the anterior and posterior plane, and then we just take a forceps and do something like it's schisis, but we just, like, the manner is doing like a renticular rexis, and we remove it. So that is what we started doing it, and you can see how easy it has been because of the no spot separation. So what we do is, we delineate both the anterior and posterior plane, and then we take a micro incision forceps, which is 23 gauge, and then we move forward parallel to the limbus with continuous tangential traction, which is exerted from 12 to 6 o'clock circumferentially. And we do, let's say, the right side first and then the left side, or you can do vice versa also. And with this technique, because you're holding the lenticule and nearer to the attached area, there is minimal chances of retention of the lenticule. However, you have to look for it. So now what we have started doing is, with optimization of energies, we, rather than doing something like a circumferential movement, we just push the lenticule inside and we remove it. So this is what we have been doing for the past 6 months with the optimization of energy. So it's not even something like you do a circumferential movement. You just identify the anterior and posterior plane. You grasp the lenticule with the 23 gauge forceps, and then push and pull. That's it. So that's what we have been doing, and it's been quite consistent for many cases now. We've done more than 400 eyes with this similar technique. It doesn't work for all the patients. Sometimes you do have to go back to the gold standard, which is the dissection, but fairly it works for your 90% of the patients. And day one, they have been having a clear cornea. If you see them on retroillumination, you can see how smooth the interface has been. The objective scatter index is also quite good on day one. And if you see the OCT analysis, there is hardly any Bowman's layer distortion or any edema of the interface. So I think we are just moving towards a technology which is going to make the lenticular extraction quite simple as we move on. Thank you.
Thanks, Pooja. That was a very nice presentation. But can you be a little more realistic in the sense, are there any kind of OBL patterns which you see when you take a call that, no, this particular case, I'm not going to do lenticular schisis? Or you think if the right way of the push and pull seems to be quite elegant, you could do it with any kind of OBL pattern?
No, ma'am. As I said, we do quite a lot of patients, but I would say that it's 90% of the patients in your practice. You cannot do it for all the patients. If it's a very thick cornea, like let's say if it's 550 or above, or if it's a very thin lenticule of 2 diopters or less, or if it's, let's say, if you have a corvis in your practice, and if it's a very biomechanically strong cornea where your SPA1 is above 100, then I wouldn't attempt this for sure. Because I know that there I'm not able to I will not be able to do this technique. I just have to, then I go back to the gold standard of dissection. So there are cases, even if you optimize the energies and all, this may not work. So that's when you go back to the gold standard. So I suggest myself that don't do it for all the cases. And of course, if the OBL is dense, sometimes you see a very dense OBL at 3 and 9 o'clock, or the entire 0 to 180 degree, you see a dense OBL. That's when also I try not to attempt it.
Dr. Sonu Goel, do you have anything to add to this before we
I think Pooja has always something new to add, and I think that's an excellent technique. Congratulations, Pooja, and your group for
Thank
doing
you,
this
sir.
wonderful thing. And I also second that it doesn't work for all patients. We have been doing lenticoschisis for off now, but I think yes, optimization of energy, and then I think Dr. Sri Ganesh, guess escape pattern is one very important sign, and I feel whenever you have that sign, the dissection is quite an easy job. So all in all, I think it's a wonderful technique. And how many cases, just a quick question, how many cases you had incidence of, the lenticle tear? Or I think I had multiple cases where I was doing 2 millimeters, the cap side cut, and a lot of patients had that cap side tear. So I think it works very well in expert hands. And yes, the OBL pattern has to be really looked into.
Yes, so I have had 3 or 4 patients where I had a lenticule tear, and then it becomes a little messier to go and remove it, but it's at the edge. So with little magnification and a little different, even a minimal forceps, you can go ahead and remove it. But now if I see a different OBL pattern, as you mentioned and ma'am also asked, we try not to attempt it.
Yeah. So yes, that's definitely a way to go. Anyway, if the lenticule actually gets stuck to the cap, I think all of us are doing lenticuloschisis only to remove it. So here, once she has separated the two planes, I guess, and I quite like the way she pushed the lenticule inferiorly and pulled it out. You want to tell anything, Shreyas, before we go on to our next speaker?
Just a quick question. While Pooja, nice video, and with the technique of lenticule peeling, whichever way we do it, while it does have the advantage of ensuring that you're not distorting the sides as much, which can happen when you're doing a manual dissection. If you have a uniform, and I think all of us agree that optimizing energy is probably the most important parameter in faster visual recovery for each particular machine. What do you feel this technique offers over a standard dissection in terms of ensuring faster visual outcomes? What do you think is the main reason why lenticuloschisis is at least proposedly has a slightly better visual recovery than the regular dissection technique?
So we have you, Ramurthy sir, Rushad, I think, who have been using silk. What I have seen in silk is sometimes if you take a little longer time in dissection, or even if there is a tough dissection, and even if you are moistening your cornea regularly, there is always some sort of edema you see on table. And even if you start them on steroids 1 hourly, day 1, the quantity of vision is not good. So what this technique has an advantage is it just reduces your dissection time. So, sometimes if you have identified the anterior and posterior plane correctly, then you just saw that either you can do something like a rhexis or just push and pull. So that just reduces your dissection time. Otherwise, it becomes sometimes messier. And I've had a patient, sometimes if my fellows do a case of silk, then day 1 they are 6'9", and they take a week to recover or something. But at the same time, when they do a peel technique, which we give it to our senior fellows, because it's less manipulating, because it's less activation of keratocytes, which we have seen on confocal, the day 1 quality of vision in the same hands is much better. So even in beginner's hand, when we have tried, the recovery of quality of vision is little faster here than compared to that of dissection.
This is in any way machine specific, or it can be replicated across all platforms?
Sir, as Sri Ganesh sir has always been doing it, Sonu Goyal sir also mentioned he's been doing it for all their patients. So, it can be replicated at least on Visumex, Smile, and Silk. I've tried doing it on Atos, but because the Atos doesn't have a side cut, as in the edge of the lenticule, we have not been able to do it very meticulously in Atos right now. And Zemer, I think one of, as in you can try, sir, and let us know. But this Atos, I'm not yet able to do it.
The old adage was there many ways to skin the cat. Now it's to peel the lenticule. Many ways to do.
Yeah. It's like you started from your capsulotomies and now you do rexes for all your cases. So it's like a flax procedure. The lenticule is already separated, but like how you have done a flax and you go and still hold a forceps to remove that some attached areas, it's something like that.
Great.
Yeah. Thanks, Pooja, but I still believe that you need to have a nice OBL to get that kind of visual outcome in these patients too.
Yes, ma'am.
But yeah, you have a nice way of debating for your cause. So we go on. Thanks a lot. Have a nice holiday. If you can stay on while the other speakers are there, it'll be a big help.
I'll be online, ma'am. Yes.
We'll be going on to our next speaker, Dr. Rushad Shroff, who's the medical director at Shroff Eye Care Center, Eye Center, Delhi. And he has another interesting situation, managing dark spots in relax. So on to you, Rushad.
Thank you so much, ma'am. Is the screen visible?
Yes, screen visible.
Thank you, and thank you for the invitation. I'm going to be moving from peel to a dreaded thing that we sometimes see in lenticule extraction, which is dark spots. And at the outset, I'd like to say there are no financial disclosures. So the causes of dark spots are inadequate laser delivery, which means that the femto laser is not firing the correct amount of energy into the stromal interface. Typically, it's because of debris or secretions on the surface or on the material on the patient interface. And this tends to happen more in cases where you're doing repeated docking. So I'm just going to show a couple of videos regarding cases where we've had issues and how to manage these dark spots. So here you can see there is this patient being docked under the ELITA system. You see that there are some kind of debris, but they are tending to go away as we are docking onto the cornea. So you see now it's docked, but as the laser is firing, what we notice here is a very, very large dark spot appearing, which is pretty much in the visual axis in the pupillary area. So the question in this was, why did this actually happen? And the answer was, when we applied the PI, you can see this. It's a very important thing to check the PI. You can see that secretion is right on the glass of the PI. And the surgeon didn't notice this, and that was why that happened. Now, the second case I'm just demonstrating is another case where we had a higher myopia, and then we had a little bit of dark spots appearing, and then how to handle the dissection if you do actually manage to go ahead. In that first case, we actually had aborted and we had done a PRK later because it was in the visual axis. So here you can see it seems like a reasonably regular dock. I showed a wiping of the surface to make sure that the debris are gone. Now you can see the laser is starting to fire. And again, we noticed some amount of dark spots, not to the same extent as they were in the first patient, but you can see that there are these two large patches where the laser seems to have created uncut areas. Now, in this kind of case, you're in a dilemma whether to actually go ahead or not. In this particular eye, we did because it wasn't exactly at the visual axis. It was just tending to touch the pupillary area on the inferior left. So typical technique where we go into the anterior plane first and then separate the posterior plane. This part was relatively okay, but I knew that it was going to be a little more challenging as we got further into the dissection. This is a slightly older video. What I've adapted to now is I normally use a forceps to stabilize the cornea, hold at the limbus when I'm doing this, because it just reduces your chance of causing any kind of perforation of the cap. What you can see is that definitely this dissection is a lot more challenging and difficult than it normally is. You start with the areas where it is actually dissected, and you try to separate those out with gentle strokes to the side. What we are noticing is that inferior area is quite adherent. So I switched from the sharper dissector to the spoon type. I do find
Doctor,
this.
1 minute more.
Sorry?
No, it's okay. Carry on.
So you can dissect a little more easily with this when you have dark spots, and this is my preferred dissector when I do encounter these. And you can see gently we're trying to break all these adhesions as we go along. So gently with rocking movements from side to side, trying to ensure that we separate both the anterior and the posterior plane completely before attempting to actually remove this. Because if you try and remove it without separation, there can be tags, and then that can cause a tear of the lenticule. So what we found was we did that. We went into the posterior plane. We're just reconfirming, just making sure that this is separated. There is an area of tag at around the 7 o'clock position, which we're not able to get rid of completely, which I'm going to then take with the forceps. Now, we did manage to get a grasp push towards the 6 o'clock position and then pull back. And then eventually we managed to extract the lenticule. In this, it's always important to make sure that the lenticule is complete. And that's what I'm doing here, just to ensure that it's a circular lenticule. And then we proceed. So the points to remember, according to me, in this is if it involves the pupillary axis, just be careful about going ahead with the dissection, because the stromal damage can cause irregular astigmatism, which becomes difficult to treat later on. Dissect the cut areas first and then move towards the uncut areas in gentle swipes. I've started using a forceps to stabilize the globe. It helps a lot more. And if noticed early, there are talks about creating a deliberate suction loss and converting to a flap as well to rescue this kind of situation. So with that, thank you. And I would appreciate any comments and
Yeah. No, very valid points, Rushad, like ensuring that you don't unnecessarily get into a situation of repeated docks and undersurface being kept dry, and also ensuring meibomian secretions are washed off. All that is very critical. But let me ask Vardhaman. You are there, Vardhaman? Yeah.
Yes, ma'am.
So do you
Yeah.
have some kind of a threshold that if there are this much of dark spot, you would convert it to a flap, or you would be valiant enough to try it all? Because I think the only thing is going to be a suboptimal visual outcome the next day if there has been too much of dissection. So what are your
Right,
thoughts?
ma'am. Yeah, ma'am. I think first, beautifully presented by Rushad. I think
Yeah.
he tried to go on to all the aspects. I think I agree that if the dark spot is in the visual axis, especially, and if it is a significant dark spot, then it may not be a good idea to proceed with the dissection. Maybe I think it may be a good idea to, depending on the let's say availability of the time frame, either to come back again and do smile some other time, or make it into a flap this time, or even do a surface ablation treatment. But if it is in the visual axis, if it's a significant dark spot, definitely I think I will avoid to do a dissection. Nowadays, fortunately, it has become extremely rare. Actually, I think if I really see in last probably few years, I've not had any patient to have this kind of dark spot. I think the most important thing will be to be very, very careful about the interface, that there is absolutely no debris. Fortunately, in Visumax, as against in I think Elytra, we have excellent visualization when the docking is done. And therefore, I think even if there is a small speck of a very small debris, we definitely come to know about it. And then definitely it is not a good idea to proceed. It is better to clean the docking interface and then proceed with the application of the laser itself. But yeah, I think I will agree that if it is in the visual axis, avoid it. If it is in the periphery, it's very small. Definitely you can dissect it. It is quite possible. Yeah, but it has now become quite uncommon actually with the current energy optimization and being very careful about the interface.
While you're on top of these dark spots, is there a consensus that which kind of, sometimes we have an unexpected difficult dissection, either in which kind of corneas do you think, Rishi, you think you might expect that difficult dissection? That dark spots have become very infrequent because we're all very particular about the undersurface being dry and no meibomian secretion and all that. Do you feel there's any moment in any particular cornea when you feel that the dissection is, you sort of expect it to be a little tougher?
I think it depends on the OBL. If you get a nice OBL pattern, I don't think there are specific corneas in which you get easier dissection or difficult dissection. You can correct me if I'm wrong. It's just that some corneas you get a better OBL and some you
Yeah.
don't get a better OBL. That's I think it's just about that. So your energy setting, optimization, etc., is I think more important, and how well you dock. I think that is the key.
No, I think
Ma'am, can I?
the
Yes.
points made by Rishi is absolutely relevant. But just by the way, maybe a stronger cornea, like Pooja mentioned during her presentation, even for the peel technique. If
Thicker cornea.
you see that the curve the thicker cornea, stronger, where the curve shows a higher tensile strength, maybe there could be a little more resistance. Very nice presentation, Rushad. I mean, I just want a clarification. You said absolutely agreed, and Vardhaman also said that if there's such a large dark spot in the center, better not to proceed with the dissection. But instead of postponing it to a PRK later, could you have used the circle software and convert it to a flap and complete the treatment right away?
In ELITA, there's no circle software, there's no rescue mechanism, so I can't convert to that. So
I was
one
surprised you
point
got
that-
such a good smooth dissection at the end with such a big dark spot.
Yeah. Actually, but
Can I make a comment, ma'am?
yes, Natasha.
So Rushad, wonderful presentation. I think we've all had this in our earlier, cases that we've done. I started keeping a disposable dissector. So if I'm having a dark spot which is less than 2 mm, I don't even try to manipulate with anything else. So the areas where it is the OBL is very beautiful, and I don't get a black spot. In that area, I dissected with the normal smile dissector that we conventionally use. But in the area where I have a dark spot, just in that specific area, I put in a dissector and sort of cut it out with a manual dissection.
Yeah, that's why I switched to the spoon also. It makes it kind of like that. That was one reason of doing that. The second thing, sir, to your point was that at least in ELITA, I've noticed that I have different energy settings for higher myopes versus lower myopes, and I keep a slightly higher posterior value of the energy, and that tends to help a bit more with the separation. If you keep lower energies, which we are trying to do for our, say, refractive errors of 3 and below, I have a different setting for that, different setting for 3 to 6, and then above 6, I have a different setting just to kind of take care of these issues as much as possible. And the first case, of course, it was just about looking at the PI. I mean, it was a new PI, so no one bothered to check it. And then suddenly, when you go back and see the video, you see that huge secretion on the PI. It wasn't on the patient, actually.
If you've had in an extreme situation, which might not have happened to any of us, if you have had a tough dissection and you've not been able to separate the lenticule, but the lenticule, you guess, might be a little folded too, would you actually ever do a surface ablation on the same sitting, or would you abort it and take it up later? Expert panel or anybody on the comment on that?
Once you dissected the lenticule, and especially if it separated the posterior plane also, it may get a little irregularly placed as well. So that itself will cause some irregular astigmatism, I feel. And it may alter the refraction. So once you've initiated a dissection, I think it's better to just try and get it out and deal. Maybe a circle software would be a better option, if at all.
Yeah. Yes. Thank you very much, Rushad. Wonderful.
If I
can make a small comment.
Yes, Shreyas.
Yeah, sorry. No, wonderful video, Rushad. And this is a problem over the years with Smile Silk. I've encountered it many times. And unfortunately, with that many number of cases, I felt that alteration in the dissection technique, which helped me, is that traditionally we do the anterior dissection first and then do the posterior. But in these cases where there's a dark spot, and generally if you see, the deeper the layer, the less the energy has gone in. And usually, even though the dark spot is in the anterior surface, the anterior cap cut is a little easier to do than the posterior lenticule cut. So generally in these cases, after delineating the lenticule, I complete the posterior first, because you want some counter traction. When the anterior is still attached, you're able to use a little excessive force, but still the lenticule doesn't fold or doesn't bunch up. If it's right in the center, it's easier. I mean, in a way, at least to complete the dissection, because you can use a little bit of force and the lenticule won't fold. But if it's towards one side, then when you go to that side, it folds up from the opposite direction because your counter traction is lost, and it becomes difficult to complete the dissection on that side. So a useful thing which I found for myself is that I usually do the posterior first and then come to the anterior and complete it. And usually you're able to remove the lenticule in toto and even in these situations.
That's a nice point, Shreyas. And actually, I kept switching between anterior and posterior in this particular eye. I've edited it, but I'd done that anterior part, then I went posterior, I did more of it, then I came back anterior. So that actually makes sense. And now that I think about what you're saying, that's pretty much intuitively what you end up doing anyway.
Yeah, that's true. And quickly, one addition to that, generally, while it is easier to dissect the other areas first, I would still not dissect the area where the OBL is clear. Again, just to have that lenticule traction there. So I will go around the area of dark spot, complete the dark spot area, and then do the areas where the OBL delivery is very good. So laser delivery has been good. So that also helps in easier dissection.
Yeah. Makes sense. And with these valuable discussions, we go on to our next speaker, Dr. Tushar Grover. Tushar Grover is again a medical director at Vision Eye Center, Delhi, and a senior consultant in cataract, cornea, and refractive services. And Tushar is now going to take us a little away from SMILE for the moment. He is going to talk on phakic IOLs for keratoconus, friend or foe. So on to you, Dr. Tushar.
Thank you, ma'am. Very good evening, and thank you for having me here. So I'll be presenting the case as you said, and I'll call it when less is more, and it'll be clear why I say that. So starting out with the case scenario, this is essentially this is a 34-year-old male who's a known case of keratoconus, having advanced keratoconus in the right eye, mild in the left eye. This is stable keratoconus. So the individual has undergone C3R in the past and is stable now. Subsequent to the C3R, somewhere else, the patient had also undergone a toric ICL in the right eye, and this was 3 years ago. Now, these are the visual acuities. The right eye is 6-9 parts, which is not bad for somebody with this kind of keratoconus, but the individual is extremely unhappy, has significant uniocular double vision, ghosting, glares, halos, etc. Extremely unhappy with the vision. Now, when you look at the corneal topography, this is what it is. You can see it's a significantly decentered cone. You can see the cone sort of bisecting the visual axis here. When you look at the EKR map also here, you can see the histogram that's pretty widely spread out. The standard deviation is quite high, which again indicates across different zones, it's an irregular cornea. So not a great candidate for a toric ICL or any kind of toric IOL for that matter in this particular case. When we went ahead, did a scleral lens trial in him, there was a considerable amount of cylindrical over refraction and the vision was still not improving beyond 6-9. And with that cylinder incorporated, also the scleral lens was rotating and therefore was not stable. And the patient continued to be unhappy because we were not able to get rid of the symptoms for that patient. So it was a difficult decision and a difficult discussion to have, but the patient was more than happy with the possibility of getting the ICL explanted because the patient reported significant worsening of symptoms after the ICL was implanted. So this is the technique that I usually use to explant a phakic IOL, the two-hand technique where you use two blunt forceps, and the ICL was explanted quite atraumatically. As expected, the uncorrected vision did drop to 636. This is something you would expect. But when the scleral lens trial was done subsequently, you can see that the over refraction obviously is going to be very low. We were able to overcome the irregularities, and this time the patient's vision has improved to 6.6. So now the patient was extremely happy because though the uncorrected vision is lower, but the patient is much more comfortable with the vision with scleral lenses, and therefore subsequently no intervention was needed in this case apart from the ICL explantation that was done. Now, the reason why I chose this case is that when you have a decentered cone like this is a slightly altered image just for demonstration and illustration. So when you have a decentered cone like this, it's important to always do a scleral lens trial or an RGP trial first. And if the patient's happy with vision from a scleral lens, then that's all that needs to be done. And if you do plan on doing a phakic IOL, it's important to either regularize the cornea first using a topo-guided PRK or centralize the cornea, centralize the keratoconus cone with an intracorneal ring. Thank you.
Thanks a lot, Tushar. In a decentered cone, if the patient's best corrected vision with glasses is good, then maybe you need not do a topo-guided regularization, and you could do a phakic IOL and get away with it. I think there were a lot of aberrations on the cornea of this particular patient. It is not just the decentered cone alone, of course, so that could be the issue. I would want others' thoughts on that. And the other thing is, the other question I have is, in an age-stabilized keratoconus, expert panel, would any of you consider doing a phakic IOL without doing cross-linking? Shreyas? Shreyas, are you there? It's not there. Okay, Dr. Ramurthy? You have to unmute yourself. We can't hear you.
Very nice presentation, and I truly feel it brought about a good point that, in case the simple factor we go by is that if the patient is having good visual acuity with the spectacle correction, then going ahead and implanting a phakic intraocular lens makes sense, because what the phakic intraocular lens is something like the spectacles, where it takes care of the lower order aberration, that is the sphere and the cylinder. But if he or she requires a contact lens, especially a rigid contact lens, a scleral contact lens, or a rose scale lens, obviously there's a significant amount of higher aberrations, and the phakic lens is just going to make things worse. So that's whether it's keratoconus or iatrogenic ectasia, that's something that we need to keep it in mind. And decentration is again we look for, that's in the posterior floor, where there's the nipple of the cone or the central 50% of the cone is within the central 3 millimeters. But even more important, we have put a phakic intraocular lens in some slightly decentered cones, not grossly decentered like was shown here. But in these cases, again, if the visual acuity is good with spectacles, then you can venture with phakic intraocular lenses. Otherwise, it's always, as was very nicely shown, centralizing it with the TGPRK or with a intact segment would be a good idea. And then 3 to 4 months later, we can place a phakic intraocular lens. As far as your second question about doing I think whether it's age or whether it's CXL, which is stabilizing the cone, once it is very stable and it's remains so for 2-3 years, then I think there's no harm in going and placing a phakic intraocular lens, especially if the patient is above 35 years of age or so. Of course, there's no scientific basis on my picking up this 35, but very rarely we come across, though it has been reported in the literature, that keratoconus progresses after that age.
So one thing definitely comes clear, Tushar, your talk was brilliant. Very important point came through, that if there is aberrations on the cornea, these are clear-cut cases of scleral contact lenses, and definitely not for phakic IOL, and explantation is the answer. But is there any nuance about the phakic IOL measurement details? Anything which you would want your company guys to know about these lenses? And what would it be different than in a normal phakic IOL implantation in normal eye? Dr. Sonu Goel?
So I think when you're planning for a phakic lens in these patients, and usually these patients would end up in toric phakic lenses, I would always go one size above the reading. So I would let the walt go a little up, because I don't want these lenses to rotate. So a couple of patients that we have done post cross-linking, post intacts, and stabilized keratoconus, I think this technique works well, and I would always expect a walt beyond 750 in most of these patients, because stability for toric phakic lenses is a must in most of these patients, because most of these patients would then have rotations, and then you have to go one step up in these patients.
Actually, what I do believe is the central anterior chamber is going to be deeper in these keratoconic eyes as against the peripheral anterior chamber depth. So we have to mention both. And I would go for one size smaller in these eyes, because the central anterior chamber value is alone considered, then you might end up, the lens sizing would become big. So I would want to err to be a smaller lens so that I do not have a high vault.
But did you experience rotations in these patients with one size down?
I have only noticed an optic capture happening if in a phakic IOL, if the company people have not factored in that this is a keratoconic eye, and they have just taken into consideration the AC depth, which is deep in the center. Dr. Ramurthy, would you want to add anything? You need to unmute yourself.
I agree with you, Chitra. I mean, in the sense that, Sonu, we have done quite a few cases because there is a central steepening in the cornea. And if you say you get a 3.8, 3.9 millimeters of AC depth from the anterior surface of the lens to the back surface of the cornea, but in the periphery, it's quite shallow. So because of which there is peripheral crowding, and we find that there are cases where introduction of the lens itself becomes a little difficult, and on the table itself we have an optic capture. So what was suggested that was that you take measurements in the periphery of the anterior chamber and factor that in. But obviously there's no nomogram which takes into consideration the peripheral AC depth to determine the lens sizing. So what we have started doing is to go one step lower or two steps lower. In case of Indian lenses, it's 2 steps lower because they come in 0.25 millimeters. If it's an ICL, it's just 0.5 millimeters less. Your point is well taken. These patients are largely toric lenses, a significant amount of cylinder. Even small rotation may have a deleterious impact. But then we find that it works out well in our hands when we go a step lower.
So we've been doing star in most of these patients, and we have been following with the angle measurements as well. So a couple of cases that we have done, I think the vault usually we have figured out somewhere between 700 to 800, and the angles have been like grade 3 opening most of these patients. So I think we'll keep this concern also, and maybe angle measurements also. I think point well taken from Madam in these patients.
Shreyas, you want to add anything before we go on to our next speaker?
No, I mean, the same point. I mean, rarely, I think the optic capture does happen when you end up with a high vault, and that's usually the only problem. So ever since we started undersizing by one size smaller, especially when the Kmax is high. Obviously, if the Kmax is, within the normal range, that is just a steep cornea, 48 to 50, the ACD alteration will not be as much. But if you're doing a cornea with a 55 Kmax, the ACD alteration is likely to be higher. So at least in eyes which have a higher Kmax, look at undersizing the lens by one size.
So thanks, Tushar. It was a wonderful presentation. Rather, the three of you have started it off at a very high pitch, so others have to take it forward in the same manner. So we are going to go on to the next talk by Dr. Nimrita Dhami, who's again a consultant cornea, cataract and refractive services from Tindai Hospital. And she is going to talk on something very interesting and different. Severe pigmentary reaction.
Dhami Eye Hospital.
Dhami Eye Hospital, I said.
Okay.
Did I say something different? I thought I said Dhami Eye Hospital. She is going to be talking on severe pigmentary reaction with high IOP post-PRK. On to you, Nimrita.
Thank you so much, ma'am. So I'll just begin sharing my video. Is it visible?
No.
Okay, one second. Is it visible now?
Yes, absolutely.
Okay, sure. So So we know that refractive surgery seems like a piece of cake, but if your moment isn't right and the cake catches fire, then that, my friends, is a real nightmare. So I'm going to share my unwanted refractive nightmare of a case of bilateral acute iris transillumination after PRK surgery. So this was a 25-year-old who came to opine for elective refractive surgery. So this is the refractive error. So we can say it's moderate myopia, compound myopic astigmatism. So his slit lamp examination and all the examination was within normal limits. There was a small nebular scar in the eye, so we decided to go in for PRK surgery in this patient. So the pentacam was also, corresponding with the clinical examination, and it was well within normal limits, so nothing abnormal so far. So we go ahead and do the routine procedure. So we use 20% alcohol to expedite the process of epithelial debridement. And again, mitomycin application, which is 10 seconds per diopter. We usually had a practice before this case that we used to pre-soak our BCL in preservative-free moxifloxacin 20 minutes before the procedure and then apply it on the cornea after the surgery. And then the routine post-operative as we go ahead and remove the bandage contact lens on day 4, and then we start the steroids. So up until day 14, it was a normal post-operative care was going on. We had removed the bandage contact lens and the patient was on routine post-operative medications of lubricants and antibiotic moxifloxacin, and steroids were started. But on day 15, the patient came back and he had a mild reaction in his right eye. There was AC cells grade 0.5 plus. And in the left eye, the reaction was more. It was grade 1 plus. So we just thought that this patient is having some secondary, we are tapering the steroids, so probably some inflammation is happening. So we stepped up the steroids and everything seemed to be under control. The IOPs were fine. But things kept worsening for us. And on day 16, now the patient had elevated pressure in the left eye. So now we started tablet acetazolamide and we started timolol eye drops twice a day because we thought some kind of uveitic reaction is happening and there is some elevation in the IOP. Now day 18, the worsening continues. Now right eye also has an elevated pressure and you see the left eye IOPs are off the roof. It is 42. And we added more anti-glaucoma medications and we just stepped up the steroids. We kept, enhancing and increasing our treatment. And we now ordered systemic investigations thinking that, we need to look into the uveitis or the connective tissue profile of this patient, that there must be something underlying it. And we took a physician opinion as well. So as you can see, this case happened with us in the COVID era. So we did the COVID antibodies also back then. But we see there is nothing abnormal. There's just mild elevation in WBC count. And there are IgG levels positive, serum IgG levels positive for varicella zoster virus and CMV virus. Although IgG is also, again, significant of past infection, not current infection. So again, the nightmare did not seem to end. What looked like a normal post-operative patient has now kept worsening. Left eye, the pressure was 52. We were at the end of our wits end, like what is going to happen now? So we thought some viral element might be there. And because of those past IgG levels, we added tablet valcyclovir. And I think we spoke to everyone whom we could to find out what is happening in this patient. And nobody seemed to have a clue and they could not suggest any more medications what needed to be given. And at 52, the epithelium also came off and the patient was like, I cannot see anything. And it is a blinding moment in a patient who seemed like a normal post-VRK patient, was very, very uncomfortable. And we really did not sleep for those 1 or 2 weeks when this was happening. And again, now it is 21 to 28 days we are dealing with this patient. You can see we've added oral glycerol, tablet acetazolamide, we've added serum port load, mannitol infusions are going on, but nothing seems to be working for us now. And we thought that, probably we now need to take a second opinion for this patient because now we did not know what to do. So we sent this patient for a second opinion and we took a second opinion from PGI Chandigarh. And they delineated very beautiful properties. So this is how the eye looked. You can see the pupil is pharmacologically dilated. And you can see this is the amount of pigmentation that was going on in the eye. So these are the dense pigments in the anterior lens capsule. So these are the unique points of this case. And if you see, there is, characteristic keratic precipitates were not there. In fact, they were minimal or none. There was just pigment and pigment dispersion in the anterior chamber. And this pattern started appearing in eventually not, I think because our eyes are deeply pigmented, we did not see these defects then, but a month or two later, this photograph was taken. As we can see, there are diffuse transillumination effects which have appeared in the iris. So the gonioscopy showed hyperpigmented trabecular meshwork, and the anterior segment OCT was within normal limits. So they created a working diagnosis of bilateral acute iris transillumination, which was made by the PGI team, because there was acute pigment dispersion in the anterior chamber. There were pigments on the anterior lens capsule. There was no keratic precipitates or inflammatory cells in the AC, and a glaucoma which was refractory to AGM and anti-glaucoma medications, and iris transillumination defects. Everything which fit into the definition of BAIT, or bilateral acute iris transillumination. The other differentials were its sister concern body, bilateral acute depigmentation of iris, but the differentiation was that in those cases it is a milder variant, does not have such bad IOP spikes. The pupil distortion is not that bad as it started happening in our case, and the transillumination defects are uncommon. Next is pigment dispersion glaucoma. Although this has a chronic history and slow gradual rise of IOP and posterior iris bowing pattern, as I had discussed, that ASOCT in our case was normal, and this was a very acute presentation. Another is pseudoexfoliation, which has microfibrillary deposits or peripupillary transillumination defects not seen in our case. And another one was viral iridocyclitis. However, unilateral keratic precipitates and inflammatory cells are more matching with the picture of viral, which was unlike our case, which was very acute and bilateral and only pigment. Although glaucoma and iris atrophy fit the picture. So from where did this thing come out is that we thought, so this was the treatment modifications. Although the literature suggests that systemic moxifloxacin has been reported with BAIT or buddy cases, and now even in cataract, there are a few case reports where in cataract, after cataract and implantation of intracameral moxifloxacin at the end of surgery, they have suggested and seen buddy or BAIT cases. So we also had with topical use of moxifloxacin, or the pre-soaking of the bandage contact lens with preservative-free moxifloxacin, this practice which we have now badly abandoned, was possibly the cause of this. And this is possible association of systemic is there in literature, but our case and a few other cases now I have seen have come up with topical use or intracameral use. And oral antivirals were continued, and systemic and oral steroids were gradually tapered to rule out the component of steroid responsive also. And we were at the verge of now planning a trap for the patient, but then the IV mannitol to tide over the acute crisis was done for a week, and then we saw that the IOP started, coming back to the normal range. The disease started waning off, and the patient started feeling better. So just when we were about to go into, the planning of a trap, where the pressure started coming down and the nightmare started to end, and slowly, and all the anti-glaucoma medications were stopped. So this is the course of the disease, that over the next 4 months, the disease had a waxing waning course with intermittent IOP and inflammation spikes. The pigment dispersion lasted for a median duration of 4.5 months in the right and 5 months in the left eye. And the IOPs are mentioned. Now, this is the picture of the patient currently. You can see that he has the pupil has sustained a the pupil has sustained a dilated, distorted shape. This is the left eye. The right eye is still better. He does wear glasses. He has, sustained a good amount of glaucomatous damage, and there is a significant posterior subcapsular cataract also. However, he's still maintaining a best corrected vision of 6/6 with minor correction. And since last 2 years now, the patient is asymptomatic and is only on lubricating eye drops. So this is my unique case of BAIT after PRK surgery.
Yes, thanks a lot, Namrita, for showing a very rare scenario for us, and because moxifloxacin is being very often used in our practices. Now, the other thing is, since Suhasini is there, a glaucoma person, Suhasini, you know, many of our patients who undergo laser corrections are myopes, and sometimes pigment dispersion could be associated. So, do you think we should do a routine gonio as a part of our refractive surgery screening in all our cases? And if the patient does have a lot of pigments in the angle, pigment dispersion syndrome, would you actually not take them for refractive surgery? Subhashini, you have to unmute yourself.
Quite a interesting. Yes, ma'am. Can you hear me?
Yeah, yeah.
Yeah, I have unmuted.
Yeah.
Am I audible?
Yes.
Quite an interesting case she has presented. So it's very unusual to have such a presentation. I mean, from the heading, I was also thinking of pigment dispersion syndrome. So it's not quite uncommon to get because they're all young myopes who are getting operated for refractive surgery. So there is a chance, there's a high probability of pigment dispersion syndrome in these patients, in these people, set of people who get operated by LASIK or by PRK. But actually, I was in fact thinking in terms of steroid-induced glaucoma and all that. So, but answering your question, ma'am, as a routine, actually, it would be a good idea to do because just hyperpigmentation of the trab meshwork it alone can be a finding. Seen in pigment dispersion syndrome. So there need not be a Krukenberg spindle, the classical findings. So it would be a good idea to do this. But in fact, I have done some 2 cases of LASIK in these eyes in pigment dispersion syndrome, and the results are no different from the others. The outcome is the same. It's not that they develop more pigment dispersion afterwards or develop high pressures. But what we need to tell these individuals is they need a longer follow-up because a subset of patients will develop pigmentary glaucoma later. So we need to, if they are on long-term follow-up, if those people go in for high pressures later. And again, the other issue is the cornea also, it's all now, the corneal thickness is reduced. So you might have misleading IOPs. So all this can make it difficult to make a diagnosis of pigmentary glaucoma later. So because your IOPs are on the lower side and you're not sure. So these kind of individuals, those with pigment dispersion syndrome, need to have a longer, need to be on long-term follow-up. But as you say, I think it's a good idea to do a routine gonioscopy in all these patients, given that they are all young myopes who get operated.
Dr. Shreyas, would you want to add anything to this very interesting case? I mean, she's discussed it all completely, all the differentials.
I had a question. Did you use a moxifloxacin soaked BCL in this case?
Yes,
Yes.
use that.
Yes.
I think that's the culprit.
That's the
That's the culprit. Yes, that's the
Yeah.
culprit.
So
Because
yeah, so
moxifloxacin
we've
intracamerally also has been reported to cause this kind
yeah.
of severe dispersion
Now
of
that
pigment.
now that we've reported this case, and when I was doing the literature review, because I've presented this case earlier on national platforms, and I'm just going to share an anecdote by Dr. Rajesh Fogla. He was one of the person presenting along with me, and he told me that you got to publish this, because he said that he had this similar subset in Bombay, which was reported to him, and they said they did not do such well photography as we did. So he asked me that you have to publish it, because this practice of using moxifloxacin in any surface ablation procedures, because the bioavailability increases. So that's what he said. That's this pre-soaking practice probably increased the bioavailability of moxifloxacin, and then we were giving it post-operatively also, because when your epithelium is going off, you still the one thing that you don't want to remove is the antibiotic from the whole thing. And our regular practice of using moxifloxacin has been so pertinent that this is the one thing we did not withdraw. We reduced the steroids, we increased systemic steroids, we did everything, but we did not do this. So this was the culprit. But I'd just like to add that My father-in-law has been doing this. Dr. Dhami has been having this practice for 20 years. And in COVID era, we just started having this series of patients. In fact, I'm yet to publish. We have a series of 10 to 12 patients who had buddy, the milder variant. And this was the one extreme end of the scenario, which went really haywire. So we reported this as a separate case report. So yeah, this was the culprit. Yeah, but 20 years of practice behind it, nothing happening. And then in COVID era, we had this one bad year of PRK for us in our
Also
hospital.
said that some of these patients have an underlying viral infection too. So whether it is moxie as a culprit, but there is a viral etiology which has also been seen in all these patients.
Absolutely. And very interestingly, ma'am, I'd like to add this Bait and Buddy was first reported by a Turkish group. They had some 26 cases who introduced this term, and they kind of put all the case reports and they had this. And I found a very interesting thing that even the systemic investigations that they did, they also had IgG positive for CMV and varicella zoster virus in their patients. So in a few subset in which they found something positive, and the similar thing was in us. But again, IgG doesn't make any sense of any current infection. But I don't know, similar some viral etiology probably, or moxifloxacin doing the damage. I don't know.
I think Nimrita, when
I
you
think we
this
should go on
case,
to our next talk because there's a lot more ahead. Thanks a lot for getting us all even more interested about refractive surgery. Our next speaker is going to be Dr. Sahil Goel, who's again a consultant cornea and anterior segment surgeon in his private practice and also practicing in Dayanand Medical College and Hospital in Ludhiana. And he's going to tell us something even more tough, trapped in a black hole. And I just got a very tiny glimpse of his video, so I really want to know how he dealt with it. So on to you, Dr. Sahil. Sahil, unmute yourself.
Is the screen visible?
It was visible then, not now.
Now is it?
No.
1 second. I'll do the share again.
Yeah.
Yeah, is it visible now?
Yes.
Okay. Very good evening, everyone.
Yes,
Rushit has already showed black spots, and what I'm going to show is a slightly exaggerated version of the same. This was the first eye, minus 6.5 diopter sphere, no cylinder, what I would call an ideal case for a lenticule. Left eye, unfortunately, at the end of laser firing, showed such a large area of misfire. We had never seen such a large area of misfire. Now, ideally, this case should be abandoned, and after a couple of months, PRK or maybe if at all a femtolasic could have been planned. But I think we end up putting ourselves in a lot of pressure when we commit to the patient next day visual recovery. This particular patient was an NRI patient who was here in India just for less than a week, and the treating surgeon had promised him within a couple of days normal vision. That pressure sometimes makes us take bad decisions. Now, this case, as we have already talked about, whenever you see a black spot, black island involving the pupillary area, we ideally should not touch it. And in this case, as you can already see, the half the pupil seems to be slightly visible. Any case, at the end of the laser fire, you can see from behind at the interface PI, you see some of these deposits. And when you take off, you see this kind of deposits at this plastic interface. It could be easily scraped off with finger. Any case, these were the energy settings, anterior 41, posterior 43. This was just 3 months when we had started doing our cell colorita platform. So, as I said, and I would like to repeat, ideally, it should not have been proceeded. But in any case, when the decision was taken to proceed, this was how it went. Anterior plane, posterior plane. There was a lot of resistance in the anterior plane as would be expected, specifically the superior half, more so on the supratemporal side. Now, this particular area, because the laser had not fired despite multiple attempts, it was really difficult. But anterior plane, we could still get through. At the end of it came the real challenge, starting or entering the posterior plane. If it were the inferior half, we could have gone in the superior half and maybe peeled off like shown in earlier videos or tried a lenticular rhexis. But as you can see, despite taking a blunt dissector, we could not enter behind this area. And ultimately, because of a lot of resistance, the surgeon ended up perforating, as you can see here, perforating the lenticule. It was a 4.5 diopter, around 55 micron lenticule. But still, with the dissector, it ended up perforating. And as you can see here, This was the only area probably where laser had fire, and this was the only area where surgeon could enter the posterior plane. This entire was a barrier which prevented the surgeon from going and crossing this barrier in the posterior plane, reaching what was otherwise a smoother area of dissection. So this area and this area we could not enter. And now that there was perforation of the lenticule, we had already crossed point of no return. Before this, if we had stopped, we could have easily converted into a femtoelastic or PRK later. But now that the lenticule is torn and distorted, it had to be removed. Now, the surgeon tried to go inferiorly and tried to scrape off the lenticule. When it did not work with a smooth instrument, what was tried was a Sinski. So with the Sinski, we tried to scrape off the lenticule, and finally we could get that edge here. All through, multiple small edges were picked up. And because this area the laser had fired, ultimately this half was dissected and we tried to peel off using a forceps. So when we had enough lenticules separated, that forceps could grab the end. We tried using the forceps and tried initially gently and later with slightly higher force, peeling off the lenticule, gradually pulling it towards the main incision, as you can see. Inferiorly, the amount of resistance or the force applied was lesser, but gradually, as we kept reaching superiorly, the amount of resistance increased, the amount of force needed increased. The idea was if we could peel off to the superior... Hi, Dr. Rishi. So idea was if we could peel off and bring it to the superior pupillary area at 12 o'clock of the pupillary margin, at least we would have cleared, and we were fairly able to achieve it. So now, as you can see, the lenticule has reached almost superior pupillary margin. This much area was reasonably clear, but now rest of it is stuck. As you can see, we are trying to pull out, but with such pressure, the lenticule itself, the way that it is holding is peeling. So ultimately, we had to convert to a semi-flap because we did not have circle software. Caesar was the only option. It looks very crude. Even we did not have the Caesar at the laser center. We had to get it from another place. With the help of another person retracting the lenticule, a crescent was used. Blunt dissection was carried out by opening it up like a plex. So this area we had already dissected. The rest of the area was dissected using crescent. Just at the edge of the area, we had these two islands of stromal tissue on the bed. This particular island and this particular island, which was scraped off using crescent because this area the laser had fired. After scraping, there was still small area of island left over here, which was ultimately held with vanas and cut with a Caesar. We continued to smoothen the bed. You can see the edge of the lenticule. This was the wall, which was the edge of the lenticule. The stromal bed was hydrated. Again, try to see if there is any residual stroma. And then finally, the interface was washed and the flap was reposted like a hemi-LASIK flap. At the end of this, we were not sure what we will get. We had our fingers crossed. The patient had to return back to his country after a week. We'll come to the results later, but I'll take you to the video of docking. As you can see, while docking, there was absolutely nothing wrong on the interface. The surgeon even cleaned the cornea with a sponge. But as you can see, I'm going to pause here. There was a small area which you can see a sort of a black pattern, which was initially not seen. This area, if you can now gently see, there's a very small, very poor contrast, but this particular area, you can see some deposit here, which came after the applanation, which was not there before docking. Now, this was what it looked like at the end of laser fire. So, though we could get away with it, but it's not the ideal case scenario, and we have to be cautious while promising next day visual results. This is how the patient's topography look 3 days post-op. As you can see, this is anterior axial and tangential curvature. There seems to be slight asymmetry, but if you look at the actual numbers, it is 39.3 and 40.3. So the asymmetry is only one diopter. Grossly, the surface looks relatively uniform. And as you can expect with this topography, patient was 6'6" on day 1 itself. To look at more subtle changes, that the tangential curvature also shows relatively uniform. There is some extra flattening superiorly, but if you look at the numbers, the difference in inferior and superior is not more than one diopter. If you compare and contrast this particular topography with the fellow eye, the fellow eye looks a lot more uniform, but surprisingly, the fellow eye at day 3 was 6'9" or 6/7.5, and this complicated eye was 6'6", and the patient did not complain of any visual problem at day 3 itself, which is something we could not believe our eyes with. So we got lucky, we could get away with it, but then I would like to reiterate that you find a black island in the pupillary area, do not give yourself a heart attack. It is best left alone for a later date. Thank you so much.
Yes, Sahil, that was brilliant. And I tell you, you are a very daring surgeon to have done what you did. But you know, in our microkeratome days, and that too, where there was so little information about, We've done very, very difficult situations, but we were very lucky to come out of it. It just tells you that the cornea is truly very forgiving.
Very forgiving.
The message is that we do not touch these eyes. Now, our next question is, if you do not touch these eyes, that would you do a surface ablation on the same sitting? Shesh, I want your thought on that. Dr. Rishi, I would
Never in the same sitting. I think Sahil should have had it. I mean, we discussed this case before also, but you should have had a disclaimer about please don't try this at home. So, but I think anyway, I mean, this is probably a rare situation.
No.
One small tip I would want to give on the Silk platform is there is a illumination button in the right knob, and that's usually at low. And if you turn it high, these subtle interface deposits get highlighted better. So it's probably always a good idea to keep the illumination high at the time of dock, because unlike in the Visumax or other platforms, you don't see a live picture happening, and it's I mean, only at the time of dock. During the laser delivery, you don't get a live picture.
So there are two illumination buttons. The left side is external light, the right side is internal light.
Internal light.
What I've done is external light left side, I decrease it to 50%, and right internal, I increase to maximum. Retrospectively, I was able to see in the video that there was slight interface deposits, which was not there before docking, which was seen only after docking. But now we are more alert about it.
So then, Rishi,
ma'am, I'd like to add a point here.
When would you do surface ablation?
No PRK same sitting. I'm sure everybody will agree.
Yes.
Ma'am, I'd like to add a point here.
Yeah.
I really like the word that Dr. Sahil used. I wanted to add it in the previous dark spot presentation also, that we need to identify between a spot and an island. A spot can be taken care of, an island cannot be. This is clearly an island. It's a very big zone and it is not supposed to be touched. And I think regarding your question, if a PRK on a same
It's
sitting,
not an island.
it is an island. It is not a spot. So an island should not be
It's an
touched.
entire
A
huge
spot can
island.
be. Yeah. So I really like that important catchphrase here is that if it's an island, please don't touch it. And another thing that regarding the second sitting thing, if you're planning like in Visumax 800, if you're planning your the cap at 130 or 120, regarding the same sitting, you can wait for the OBL. We've done it because once we had a case where there was a complete island, there was no fire area. And so we made the patient wait, cleared the OBL, and we took the patient for a 90 micron flap cut. We did not do circle. We were that time not trained enough to use it, and we wanted to use it in front of the engineer first. So we made sure the OBL is cleared, and we took it at 90 flap cut, and then we did the procedure at the same sitting if there was an island.
I still feel that a surface ablation should not be done at all in the same sitting, because we will not get the kind of accuracy in our results at all. There would be
not a surface ablation. We did a flap intralace.
So even if you do an intralace, you would have some regression and you would end up with a small residual error. Even a suction loss, if you do the other measures which are suggested, you have to be prepared that there could be rarely regression in our refractive correction. So very good, Sahil, what you showed and documented also. And we go on to our next speaker. I know there could be so much of discussion in each of these very wonderful talks, but then we have so many of you, and I want my last speaker to also be given a good chance. So we go on to our next speaker, Dr. Natasha Pahuja, who is working as a Chief Cornea and Refractive Surgeon at Natasha Eye Care Center and Research Center at Pune. And she is going to tell us something under the scalpel. So let's know what suspense she has to show to us.
First off, thank you very much, ma'am, for this humbling opportunity. Am I audible?
Yes.
And the screen is visible?
Yes.
Okay, great. This particular video is basically a homage to all the teachers who dare to teach refractive surgery and make fabulous surgeons all over. Now, this was my nightmarish experience while teaching refractive surgery to a fellow. And whenever it's a very tricky situation, it's always important to make it a little funny. So that's how the video is going to be. So this is basically the medieval ages when we used to use microkeratome very regularly. A young fellow wanted to use microkeratome. So we decided to go ahead with a very simple case. The right eye was a success. So the fellow was very, very confident. and he was very sure that he's going to be a fabulous surgeon. But in the left eye, he had suction loss. Sorry. Let me just. Yeah, so in the left eye, he had a suction loss. And he said that I'm not sure what has happened. I said probably the flap has not happened, but I was hyperventilating at that time. And so the fellow was like, I don't know what's the issue. And he said, I can't see the flap. And I was seeing the entire surgery on the screen, and I saw that I could not see a flap. So I said, probably the flap has not happened. Let's go ahead and make another flap. So he redocked. And of course, the flap was made. And the surgery after that was very uneventful. But after that, I was cleaning the microkeratome when the patient was sent out. Now you see here, this was the first flap that had actually happened. And that flap was stuck in the microkeratome. After that, we made a second flap. And the laser was basically performed under the second flap. The flap was very smooth. But after that, the patient was called back again inside. And the flap that was stuck in microkeratome was fished out. And I'm just trying to basically see which is the epithelial side, which is the stromal side. Unfortunately, for this particular case, no marking was done on the cornea, and that was a huge blunder at our end. So if you see here, I'm just trying to, with the tactile sensation, understand which feels like an epithelium and which feels like a stromal, and straightening out the free flap that was stuck in the microkeratome. And I reposit this, hoping that the epithelial side is on top and the stromal side is facing the bottom. So basically the flap was deposited, but you see the free flap actually had a cut at the temporal edge. The second flap basically had a cut at the temporal edge. So the flap underneath this was also moving. So we tried to reposit that with the forceps itself. And because it was in saline, the flap has become very hydrated and edematous. But somehow we put it back in place with our fingers crossed, hoping that there is going to be no epithelial growth and eventually the second flap was sitting very nicely, and the superior flap was put in place, eventually making half and half sections to iron out the flap ideally. And it all in all, it went really well. The fellow decided not to take up refractive surgery after that. But yeah, eventually I was very lucky because this patient turned out very well. This is 6 months post-op, just a mild scar. The topography looks fairly okay. He had a 0.75 cylinder, but this is me at the end because I took the credit for fixing it. So yeah, it was really a nightmare, but it turned out well in the end. So like ma'am said earlier, cornea is very forgiving, and I really feel that is true. So thank you very much. I'll be very happy to take any comments.
Truly a challenging case. You're surely lucky that you didn't have an epithelial ingrowth or nor a flap melt or any of those situations, nor any ectasia also happening because the other cut was the deeper cut. So, Dr. Rishi, you want to add something here? Dr. Rishi, are you there? She's not there. Okay, Dr. Ramurthy?
Ma'am, can I ask?
Yes.
Dr. Natasha, that's really a nightmarish thing that has happened. I'm surprised. So I do use the microkeratome, the SBK blade, the Moria SBK motorized blade that I use. So actually, I'm surprised that free cap once it has happened. I'm the corneal luster would be lost. How the fellow has not noticed it?
You're absolutely
And
right, ma'am.
went ahead
So
and with the second flap.
So what had happened was, once that happened, because the microkeratome usually just before we put the pendulum, I was using the pendulum microkeratome. So before we put the pendular microkeratome, we hydrated with saline significantly. So the cornea was actually moist. I should have actually dried the bed. I should have taken over and I should have dried the bed and seen if I can see the edge of the stroma. And more than that, I should have inspected, because if the suction loss happened, the section loss happened actually just at the end of the motor coming back to its original position. So I was thinking that probably he didn't dock it properly, and we didn't probably achieve proper vacuum, which is why the cut was not made in the primary go itself. Because I was seeing it on the screen, and the cornea looked absolutely normal. It didn't look like a flap had been made. So which is why I asked him that probably, you can go ahead and make a flap.
Yes,
In the first sitting, the flap has not been made.
Free cap.
Yeah, it was a free cap.
Yeah.
But it was a large 8.5 mm entire flap that had been basically nudged out of its base.
Yeah.
Because the microkeratome was pulled up.
The other important thing about the whole thing is that, now you are not even sure about the limbus to limbus orientation. You were, besides having the two flap adherent together and things be going good, if the flap had not been oriented properly, you might have had a huge refractive surprise too.
Absolutely.
Just lucky.
Yeah. So, and you would have had to re-rotate the flap to reposition it, and all those things would have happened. So just very lucky that you got away with it.
The most embarrassing thing was calling the patient back. What do you tell the patient? We tell him that the surgery is done on really well, and you call the patient back. No, one piece is left. We have to put it back. That is the most embarrassing part of the surgery.
So anyways, now that microkeratomes are not being done much at all, if at all a person has had a flap loss and the cornea has become irregular, on a more theoretical note, when would you wait to do a topo-guided regularization of these corneas? The flap has got lost. We have no flap at all. And any answer to that?
I would wait for at least 3 months, because the ideal time for epithelium to grow and remodel it completely is ideally said to be 7 weeks. But just to see how much the cornea is changing, and we've seen that it stabilizes more or less in 3 months. So I would usually wait for 3 months.
So thanks a lot, Natasha. A very challenging case. Do stay connected with us. We'll have more discussions as we come to a certain number of speakers getting completed. So we go on to our next speaker, Dr. Supriya Sriganesh, who's the Executive Director of the Netradama Group of Hospitals at Bangalore, a young dynamic surgeon and who's really taking a hospital miles forward. And she's going to talk on managing retained lenticules after smile. So on to you, Supriya.
Thank you so much, ma'am, for having me. It's been a great 1 hour of learning. We've seen so much so far, and it's been very interesting. And I'll be today showing a few cases of management of retained lenticules after smile. I hope my slides are visible, ma'am.
Yes.
Okay. So retained lenticules are a unique complication of lenticule extraction procedures, and it can be caused because of black spots, thin lenticules, and improper dissection techniques. And we run the risk of irregular astigmatism. So I just want to play this one video where the lenticuloschisis technique is being done. As you can see here, this is a slightly stronger, denser cornea, and the pattern of energy has not come out perfectly. It's a sticky lenticule, and the forceps is being used to do the lenticuloschisis. So these are, as ma'am, you pointed out earlier, not all cases are suitable to do lenticuloschisis, and this is one such instance where because of the difficult dissection, there's a lenticule tear right there. So you can see that at the periphery, there's a small tag of tissue. Now, intraoperatively, when we notice these small tags of tissues in the periphery, it's imperative to go back in the same sitting and try to remove that piece of tissue with meticulous dissection. Ideally, what needs to be done is a rescue instrument like the Chansey dissector can be used to dissect the superficial and deeper plane so that the edge is dissected. Here, the small piece of tissue was peeled off and removed, and you can unfold the lenticule, and this fits like a jigsaw puzzle so that you have the entire lenticule out. And luckily in this case, we were able to note the lenticule intraoperatively itself and didn't allow it to go postoperatively. Now, there are three different situations. If there are small tissue tags in the periphery and the uncorrected vision is not affected, you can leave it alone without any intervention. If there is a mild corneal irregularity, the uncorrected vision is affected, but best corrected vision is improving to 6/6, you can consider a topo-guided PRK. If the whole lenticule or large fragments of the lenticule are retained, especially near the visual axis, a surgical exploration is required, and there are two approaches to this. The original incision can be used to explore the pocket, or you can convert the cap into a flap using the Circle software. Now, I'm just presenting three different cases from Dr. Ganesh's archives, showcasing these techniques. This is a case of a 24-year-old male who underwent primary smile, and the vision was not improving beyond 20/40, and after the resurgery, it improved to 20/20. So you can see on the left side, this is the preoperative topography. You can see a significant steepening, inferior steepening of the cornea, and on ASOCT, you can see there's a large piece of retained lenticule there. This was the video of the resurgery. So the original smile incision is being used to explore the pocket, and this is a rescue instrument. This is the Chansey dissector. It's a sharper dissector. So this is really required to go beneath and above the lenticule and dissect the planes. A meticulous dissection of the planes and the side cut is required to completely free the lenticule before removing it. So here we thought that it was, here we actually thought that it was a part of the lenticule or a crescent-shaped lenticule which was there. But upon dissection, you can see here that after removing it with a forceps and unfurling the lenticule, that it's actually the entire lenticule which was retained in the pocket. So the primary surgeon has pushed the lenticule down, it's tacoed upon itself and gone inside the pocket, and the lenticule has finally been lost. So this is the entire lenticule being removed, and after this, the patient was 20/20 post-operatively at 15 days. This is a second case where we've been speaking about black patches and not black spots. So there's a difference between spot and a patch. You can see here in the primary surgical video that there's a black patch which is there superiorly. And since it was not in the visual axis, the primary surgeon went ahead with the dissection. You can see that it's a very difficult dissection, especially for the deeper plane. And although it was a difficult dissection, it was gone ahead with. And the entire lenticule was removed in toto. So you feel like the whole lenticule has come out and it'll settle down. But in these cases of black patches, sometimes you can dissect within the lenticule and a layer of the lenticule can be retained. So this was the case. You see there's a significant steepening centrally here. And on ASOCT, although there is no significant retained lenticule and the epithelial maps are normal, on the retroilluminated photograph, you can see the margin of a retained lenticule, which is significantly seen on retroillumination. So in this kind of case is where you need to convert the cap into a flap with Circle software and explore. Here you can see the bump which was there centrally, which is just easily being picked off using a Siebel's flap lifter itself. And after removing the lenticule, you can see that because of the black spots, the interface is quite rough. So a 20 micron PTK was done to smoothen the interface, and then a BCL was placed. And after the removal of this retained lenticule and the complete smoothing procedure with the PTK, the patient did much better. So you can see here the PTK being done, after which the flap is just reposited. So you can see post-operatively, this was the change in the topography, and the retroilluminated photograph is clear and the interface is clear, 20/20 parts on day 1. This is another case where a completely false plane was dissected. The 31-year-old female presented with a history of complicated smile 2 days back, referred from another center. And the uncorrected vision was 20/60, but the best corrected vision was improving to 20/20 parts. The entire lenticule was actually retained inside. So this was the video of the primary surgery. You see, it's a good pattern, but the deeper plane has been dissected first. So you see the surgeon goes in the center and enters the deeper plane, has not realized it, and does the complete dissection. And here, as the cornea has a lamellar structure, it's very easy to enter a deeper plane. You see a very traumatic dissection is being done. A whole new plane is being dissected there. But since there's no side cut between the deep plane and the newly dissected plane, using the forceps, the surgeon is not able to remove that lenticule at all. So it was referred in this condition. On the ASOCT, you can see a much deeper plane at around 298 microns. And you see a hypodense lenticule there. So this is the resurgery. The cap was converted into a flap. And using a fiber optic illuminator, the edges of the lenticule were delineated. And most of the lenticule edge is able to be dissected by the short end of the dissector quite easily. Only the nasal side, the long end is used to complete the dissection properly. Here is very important to make sure there's no pieces of retained lenticule. The whole lenticule is brought out and the flap is reposited. You see here, post-op 1 month, the patient is 20/20 after the entire lenticule is removed. This is the ASOCT. Although there is a deeper plane there, it's one plane which has been dissected, not multiple planes, so it's not caused a significant refractive change. So proper technique of docking, energy optimization, and meticulous surgical technique are the most important things in minimizing complications and good visual outcomes in SMILE or lenticule surgery.
Thank you. That was again another wonderful presentation, Supriya. Dr. Sonu Goyal, are you there?
Yeah, excellent presentation, Supriya. And I think you and Shri, what series of cases that you presented. One point I just wanted to add that whenever you are in such a situation, I think if you do a full mydriasis and then you dissect, I think that retroillumination is a very great aid in capturing these retained lenticles. So we have tried a number of our own series, and I think it really works well. You need not to actually stain the retained lenticule under the retroillumination. You can actually outline the entire retained lenticule. And it's basically the 6 o'clock position where you tend to, in very thin thickness, thin lenticules, that the chances of retained lenticule are there. So actually, it's the 6 o'clock which you showed in 2 of your cases. Yeah. I think very nicely pointed out.
Thank you so much, sir. I think...
Yes. Go ahead. Sorry.
Yes, sir, please. I was just going to say that the retroillumination really helps. And also in very thin lenticules, what we do is we increase the minimum thickness, the peripheral thickness of the lenticule to about 30 microns so that, the chances of retaining peripheral tags are lesser, especially in low myopes.
Yes. Shreyas, you wanted to add something?
Yeah, no, just quickly, very nice set of videos, Dr. Supriya, as always. Just adding to what Sonu sir was saying, we found this very useful and dilated retroillumination, and using your cataract microscope rather than your regular refractive microscopes. Obviously, the coaxial illumination is better in our cataract microscopes. So shift the patient to a cataract theater and do it. And also using a little bit of IVTA gives that contrast in just injecting into the interface, because these granules get deposited at the edge of the lenticule. You can actually make out the retained part of the lenticule, the edges of the retained lenticule. So that also helps. And regarding that wrong plane dissection, while the one which you showed was tremendous, where somehow the surgeon has managed to go through to the entire interface. Very often what I've seen when a couple of times when I've had to remove such lenticules is where a small deeper plane has been tried. This is essentially because the surgeon believes that they have done the anterior and try to keep going posterior, do a little bit of dissection and then leave it. But most of the time, if we just use our regular techniques of how we reach our anterior plane and what you would do if you were the primary surgeon and thinking that nothing was done and just approaching it, we've been able to remove those lenticules. Converting to a flex or using circle may or may not be necessary, although you did it very elegantly, but just approaching it as if no surgery has been done to the anterior plane oftentimes works out very well.
Absolutely. When
this
you
is
have the primary surgical video, or if you have done the surgery yourself, when you know exactly what's happened, because this is the case, a case that was referred, and we had no idea what the previous surgeon had actually done. So, which is why the open exploration was done. But absolutely, using that technique of coming into the superficial plane first, because if you cannot find the deeper plane, usually you're in it. So trying to find the superficial plane instead of digging further in and trying to find a deeper plane usually helps. Going into that 1 mm gap between the cap and lenticule planes and just lifting up slightly and going to the superficial plane is a great rescue technique to find the plane and continue just with the original smile incision.
Absolutely. I mean, in fact, while teaching new surgeons for either clear or smile, in fact, I've started using that as the go-to technique for all cases rather than, the straightforward dissection that we normally do, going into the 1 mm gap and lifting it up and going into the anterior. More often than not, most new surgeons find that very easy to do, and they don't go into the same learning curve that we have in identifying anterior and posterior.
Exactly, agreed.
How late has anybody removed the lenticule?
Ma'am, it was 2 days post-op.
No, how late? How late? Beyond the like a patient has come from elsewhere and you find as a smile
Yes, ma'am.
something
It
is
was
happening.
2 days after the primary surgery, ma'am. It was referred to as
Yes.
immediate.
Have you
Yes.
done? Would you do it even a 1 year later or 2 years later? Is what I'm asking.
1 year. Usually, such cases probably within 3 months it happens, ma'am, because the patient has come to you for refractive surgery. They don't want to wait for such a long period of time, and usually the surgeons, the maximum they wait for everything, the edema and inflammation, everything to settle down is about 3 months, after which it's taken up for secondary surgery.
I think we have done about a month later after the primary surgery. And apart from the several points that were made, I think looking at the primary video of the primary surgery is really helpful to identify where exactly things went wrong. And secondly, also apart from the ASOCT, I find that topography also gives us an excellent indication as to where to expect the retained lenticular fragment to be there. Because you find that the corneal thickness is quite significantly higher there. The curvature change is there, so you can go in expecting the fragment there. Of course, using retroillumination and transtone acetate diluted also helps you to get it out more. But a beautiful set of videos. Nice.
Thank you,
Thanks.
sir.
So we go on to our next speaker, Dr. Ikeda Lal, who's a director at Delhi Eye Center, and she's now going to take you on to something more interesting. Case of a grade 4 DLK post-hyperopic glasses. So let's hear from her.
Very good evening to everyone. Am I audible?
Yes.
So I will be sharing a case that gave me nightmares for a very long time. This is the story of a 29-year-old female patient who presented to us with a hypermetropic refractive error in the right eye. She was also amblyopic with the best corrected visual acuity of 20/80. The left eye, the uncorrected visual acuity was 20/20. And if we look at the pentacam here, it's a fairly regular cornea with relatively flatter keratometries. And the corneal thickness, the minimum corneal thickness here is 547 microns. So we went ahead with eye LASIK in this patient. And we used the IFS 150. We can see here after docking, the flap creation has gone on pretty smoothly. smoothly. There is no significant OBL. And subsequently, we lifted this flap. There were no intraoperative epithelial defects and not a few gland secretions, but nothing very significant. And as a routine, we deposited the flap back and did everything went ahead as planned, very uneventful surgery, waited for 2 minutes. And this is what the patient came back with on first day post-op. We can see this kind of grayish cellularity that is present in the interface, which is visualized a little bit better on the slit. And we did an anterior segment OCT. We can see the hyperreflectivity. And interestingly, we can also see a fluid cleft here. So differential of pressure-induced stromal keratopathy was kept in mind, but the intraocular pressure was within normal limits. Given the kind of cellularity that this patient had, a final diagnosis of a DLK stage 3 to 4 was made in this patient. And she was subsequently taken up for a flap lift. So where we have to keep in mind the differentials were PISK as well as infective keratitis, although it looked a lot like DLK. So here, when I took up the patient the same day for lifting up the flap and irrigating, I decided that I should take corneal scraping as well, since I am being able to access this infiltrate. And we used a hockey stick to do that, being very gentle, not too aggressive, and not too aggressively rub the stroma as well. Then thoroughly irrigated and then reposited the flap after thorough irrigations. We can notice a few meibomian gland secretions at this point. We avoided vigorously rubbing again because that could cause a significant amount of inflammation. Then reposited the flap back and started her subsequently on prednisolone acetate eye drops 1 hourly along with moxifloxacin and tear substitutes. We also started oral steroids 60 milligram and gradually tapered. We also gave her doxycycline because I did not want this flap to subsequently melt, which is known in cases like this. In DLK, it can happen. This is after the next day after the flap lift. We can see the inflammation has significantly come down. The visual acuity has improved from hand movements to 20 by 100. On staining, we could notice this irregularity in the epithelium. The epithelium was loose at some of the areas. And this is at day 5. So the inflammation, though, has beginning to come down, but she has developed a little bit of stromal scarring, and which was also visualized by the hyperreflectivity on the anterior segment OCT. So the steroids were slowly and gradually tapered under close follow-up. This is at day 10. We can see the kind of stria and the scarring that this patient has developed. The visual acuity is now 20 by 200. And this is 1 month after the primary surgery. So here we are really thinking, is this developing into CTK? This is what the inflammation has led to, a kind of anterior stromal scarring. And is this really central toxic keratopathy? And why is it different? It's important for us to differentiate that. We all know that DLK is inflammatory, whereas CTK is non-inflammatory or more of a toxic. But more importantly, we wanted to decide how frequently to taper down the steroids, because CTK, as we know, does not really respond well to steroids. It's already been a month, and DLK usually responds very early. And there is literature to suggest that there is overlap between stage 4 DLK and CTK, and might be a similar kind of etiology as well. So we did not stop the steroids, but we gradually did taper down both the topical as well as the oral prednisolone. Now, finally, at 3 months follow-up, here we can see that the scarring has significantly come down. There's this one temporal stria, which we can see here, which is persisting. There is a significant amount of irregular astigmatism as well as hyperopic shift, and we can see the kind of irregularity that is visible here on pentagram, corresponding to the significant area of scarring. And this is a little unusual as well, because this is a hyperopic ablation. We do not expect this kind of inflammation to happen right in the center. And finally, at 5 months, we can see the scarring has significantly come down. The irregular astigmatism has also gone down. She has, with correction because of the hyperopic shift and flattening, she has achieved a best corrected visual acuity, which was there to begin with. And the pentacam also looks better. We can see that the flattening is gradually coming down. The hyperreflectivity is also a little lesser. So we have just kept her on follow-up as of now and explained to the patient that over a period of time, gradually the scarring will eventually go down and the hyperopic shift will come down. So I just wanted to share this rare case where there was an overlap between a stage 4 DLK and CTK. Thank you. Thank you so much.
Yeah, that's a wonderful process. I mean, it did look like a CTK, but it could have been very much a DLK, and hyperopic shift is so typical of CTK. Can you stop sharing, Ikeda?
Yes, ma'am.
That was a wonderful way of doing it. And I would have also started her on oral steroids and doxy, and I couldn't find a flaw anywhere, excepting that from the beginning, it somehow struck me that it must have been a CTK and not a DLK. But then how long would we actually wait with this kind of stormy episode that you would not want to think of DLK at all? Rishi, would you want to add something here?
No, I think she managed it perfectly, and I don't think anybody else could have done anything more.
Yeah. Now,
Unfortunately, these are very difficult
Just
cases, and we are literally at
yeah,
sea.
yes.
So I
No,
would just like to add, ma'am, that because it presented straight on day
yes,
one,
yes.
CTK usually would present later, and the kind of granularity and the cellularity that I saw. So I thought, basically what I thought when I saw that fluid cleft on ASOCT was probably all this inflammatory cells are the reason why this fluid is accumulating, because the IOP was absolutely normal. So that was, my thought process at that point of time.
Was
That's
it
why I
an
took a
isolated case, or did you have similar cases happening?
No, ma'am, this is the only case, thankfully, and no other case.
Sometimes they happen as a cluster.
Yes,
So I
yes.
just
That,
wondered
that can be scary. Then you have to go look at all your sterilization protocols if it happens as a cluster. But this was the only case that we encountered. I though went back and checked everything, checked my BSS, made sure that the staff was sterilizing everything properly, looked at all the labels, did the whole drill. But this was just a one-off case that responded like this. The patient did not have any history of keloid formation or anything abnormal. She did not have any systemic issues. So it was just something unpredictable.
Dr. Sonu, do you want to add anything here before we go on to the next speaker?
I think we can proceed to the next speaker. I am just driving. Yeah. Excellent.
just to quickly
Excellent.
add, if possible, yeah. No, very very nice presentation, Dr. Keda. I mean, very well managed. Just to add quickly, I think on day one, grade 4 directly on day one, something which is rare. So I think that is the only thing which should also make us suspicious of an infectious etiology on day one. And I think you did the right thing by scraping and not automatically assuming that it has to be DLK, because grade 4 on day one is a little rare. The other thing to differentiate CTK and DLK is that DLK is usually a problem of only the interface, whereas CTK involves the posterior stroma as well, and generally, which was visible on your ASOCT as well. Yeah, and CTK can be preceded by a DLK, though generally not necessarily a grade 4 DLK, but a grade 1-2 DLK in the initial day or two, and then you have the central typical picture of central toxic keratopathy. But I would agree with you on this case that it was a DLK to begin with, which then led to an inflammatory reaction, a subtle bit of scarring, and there wasn't as much posterior stromal involvement in your case, which would typically be there in a CTK.
Yeah, so
Yes.
I think that's what the inflammatory response kind of led to the scarring, and then sort
Exactly.
of became like a CTK because the inflammation was so intense. And I
Yes.
agree, we don't see these kind of stage 4 DLKs, but we live and we learn.
Yeah, that was a wonderful discussion and summarizing of the whole thing, Shreyas. And Niketa, that was damn good.
Thank you.
Go on to our next speaker, Dr. Rakshit Nadan. So he's a consultant cornea, cataract, and refractive services at the Eye Foundation Group of Hospitals. And his talk is going to be from setback to success with smile. So on to you, Rakshit.
Yeah, good evening, everyone. So I think we saw some great videos on Smile and ways to manage challenging and sticky situations. So I think much has been spoken about dark spots already. I don't know if this video is redundant, but anyway, this is the first case where we had again this island of dark spot where the laser hasn't really penetrated into the corneal layers here, both the lenticule cut and the cap cut as well. So we do expect difficult dissection here. So initially we first delineate the anterior and then the posterior planes, and the dissection can be proceeded with the usual fashion till we reach this area of dark spot where the dissection is obviously very challenging and taking a lot more time. So I think the maneuver with which I would compare this to is basically tunnel making when you are actually using the crescent blade to make an SICS tunnel. It's the same kind of sweeping motion where the tip of the crescent knife is used to gently make or propagate the plane, or to try and avoid going too deep or too superficial with that degree of care to make sure that you cross the area where you're creating a tunnel. In the similar way, once this area of a dark spot with these kind of sweeping motions with the same Shansu dissector is made, the rest of the dissection is quite routine. Of course, we do have to repeat the same dissection even for the posterior plane as well. And we have to take our time here. Of course, this is not in the visual axis, so I decided to go ahead and try and complete this. Thankfully, I was able to get past this area of dark spot, and then the rest of the dissection could be then completed as usual, as routine, and then the lenticule could be extracted in toto. So this is the second case where there was a bit of trouble with the difficulty in plane, and the trouble basically arose from this constantly bleeding limbal vessels, not very uncommon in contact lens wearers who have peripheral vascularization. So trying to again delineate the planes here, I'm asking the scrub nurse to keep washing with BSS at the site of incision. I'm here again going with the dissection. I'm assuming I'm anterior, but once the dissection is complete, I quickly realize that I'm not able to get to the lenticule interface. And then I try once, twice, and then only the third time I'm successful with this sweeping maneuver where I actually access the cap interface. And then I know that now I can go back and then complete this, all the while my scrub nurse continues to irrigate at the wound. And once this is performed, we can again extract the lenticule, again taking care to make that last sweeping motion and a rhexis-like maneuver to again extract the lenticule in toto, and make sure that it's completely circular before irrigating the interface, and then making sure there's no more bleeding into the corneal stroma. So of course, this technique was christened as the cap recovery technique by Reinstein's group, but then a lot of surgeons who had started practicing lenticule extraction have been using this technique ever since they started troubleshooting in their own cases. This case is another case again where there was a perfectly fine looking OBL, again patient losing focus here, so we're trying to create that central opening where patient can then fix on light, again delineating both the anterior and posterior planes. Dissection is rather uneventful and easy. Then again, I feel that probably I have gone into the lenticule, I've gone into the cap interface, lenticule interface first. I have dissected posterior first, and I'm trying again to use this cap recovery technique to get into the right plane. But somehow this is not happening, and I'm not sure why this is the case. And finally, I see that I've been in the right plane all along, and now I've entered into the posterior plane. This is something that I like to call the false posterior first, where you think that you're suspecting that you haven't got into the right plane first, but indeed it's just that you haven't delineated the lenticule interface while commencing the case, and then the lenticule extraction is essentially routine once you discover this, and the lenticule is extracted in toto. I think no discussion on sticky situations with SMILE can be complete without suction loss. Here again, when the suction loss occurs during the lenticule cut, obviously the solution is to the software itself dictates that you create a flap and then perform a femto LASIK in the same sitting. Of course, at different stages, you have a different line of management, and that merits a separate presentation. But I think that's about it for me. Thank you. Thank you for the opportunity.
Thanks, Rakshit, for showing something different and very nicely shown procedures. It has a learning in its own. But when is it like in our practice, you keep getting dense OBLs? When do you think it's just one-off case, or when do you ask for a technical support to go back and optimize the energy settings? Dr. Sonu Goel, Dr. Rishi, your thoughts?
First, I'd like to congratulate Rakshit. That was a wonderful set of videos, and I think the whole gamut of SMILE surgery that you presented, excellent. So I think black spot has been deeply discussed here, and very nicely the way you dissected, and time and again we have been talking. So quick pearl that you always have to take care of that the eye doesn't roll up. So I think it's a good idea to support with your left hand whenever you're trying to dissect in these sticky situations. Because the moment the patient rolls, and then you might have a cap tear or a cap perforation or a lenticle perforation, whichever plane you are. The second, as routinely, everybody has spoken about, that the spoon dissector and going all around that black spot, not chasing it right from the leading edge, but going all around the cleared area and then slowly dissecting, as you did very nicely. I think that's a great idea. And yes, I mean, for us with the 800, those days of suction loss, we hardly had 2 patients of suction loss in a series of 1,000 eyes that we had, because that 8 seconds of suction really matters vis-a-vis 28 seconds on a 500 platform. So, and the last thing that, ma'am, you asked about the optimization, I think with the experience, the kind of the OBL that you have, I think you can play with the spot size, the spot spacing, and the energy levels, and then finally tune the machine as per your the needs. I think that's the best part. Point which I just wanted to highlight all throughout was that whenever we are taking the PI from the pack, just be very, very careful not to leave any thumb impressions on the glass. I think this is one very, lightly which is taken, and then we always or frequently try to hold the interface in such a manner that you leave the thumb marks on to the glass interface. I think that is also one of the causes of having unknowingly the black spots.
Yes.
I think one more point is that sometimes these PIs come with some debris on them. So always inspect the PI. Yeah.
That's a
And
great
if
thought.
needed, use a sponge and remove that debris.
Great thought, yes.
And I think, another important aspect, Rakshit, you brought about was most often the lenticules is stuck to the back of the flap, and that's where you get it out from. But very rarely, as you showed, it is on the it is anterior dissection which has taken place, and you feel that it is on the stroma itself. And you have to understand that that can very rarely occur. And there have been couple of instances when they had to see the edge of the lenticule reflect the cap back to that extent and then go back and identify and take it out. So we have to remember that it's not always stuck onto the back of the cap, but it can also be on the stroma. And as far as calling tech support is concerned, as was very nicely brought about by Sonu, one of the rare occasions we do it is when we have a series of cases where there is black spots occurring. It's not an individual case, but number of cases where you have difficult dissection. Then maybe it's something wrong in the optics, and calling them over with the right optimization of the energy settings is called for.
Yeah.
This has helped us in a couple of occasions.
Thank you very much, Rakshit. So we go on to our next speaker, Dr. Shakti Rajeshwari, is a senior consultant in cataract, cornea, and refractive services at our EYEEDU branch of the Eye Foundation Group of Hospitals. And she's going to talk on topo-guided treatments for ectatic corneas, the challenges within. So on to you, Shakti. I would, Rushad, we look forward to your inputs too, because you are also doing quite a few topo-guided treatments. Yes, Shakti, unmute yourself and...
Can you hear me, madam?
Yeah.
Yeah. Good evening, everyone. So far, we have been seeing and discussing a lot of interesting cases of refractive surgery, challenging cases, and the way it has been managed. Now, we are moving into a quite different topic, corneal ectasia. Commonly, what we encounter ectasias are keratoconus and ectasia post-refractive surgery. So we do have quite a lot of management options, but today we are going to focus on topo-guided laser treatments for ectasia. So before going into the videos, how we plan the treatment and few case reports, I just want to highlight what is actually topo-guided PRK as well as TREC. So we have a SWIND Amaris laser platform in our branch where we perform this. So it is a customized excimer laser treatment guided by a topographic map. What we actually do is we do a detailed corneal mapping, and the topographic data is transferred into the excimer laser platform. And although algorithmic software usually interprets the data, it actually prepares a laser ablation pattern. So actually in this topo-guided treatment, we modify a lot of parameters. So we optimize the optical zone, we change the depth of treatment, and usually we give a partial refractive correction, around 50% of the spherical and 50 to 60% of the cylindrical power. And following this topo-guided treatment, we proceed with the routine cross-linking. So who are ideal candidates for these topo-guided treatment, which includes mild to moderate ectasias, minimal thickness, what we expect is 450 microns for us to proceed, and maximum ablation depth of 50 microns. So as you see in the picture, you can see a topographic regularization of the cornea following a topo-guided laser treatment. So it leads to an improvement in the best corrected visual acuity, as well as patient's quality of vision with spectacles and contact lenses. Another novel technique is TREC. Whoever candidates who are not eligible for topo-guided treatment, it means like the thickness is not adequate for topo-guided PRK. The other option is TREC, which is a topographic guided removal of epithelium. Here, what we do is the laser is being ablated over a small localized area, that is the cone, the steepest part of the cornea. So it flattens the steepest part and regularizes the corneal surface, as you see in this picture. So the topographic regularization occurs in addition to a better abrasion profile. And the main advantage in TREC is we have minimized the stromal ablation. We save more tissue whenever the corneal thickness is less. So especially it is recommended in decentered cones and thinner corneas. So this is the video how we plan the topo-guided treatment in our SWINT Amaris platform. Is like we select a picture, topographic map, then we export the file to the laser machine, and then we as you see, we enter the actual refractive values, the keratometric values, and then what is the target refraction we are aiming. So we have to go in the trans PRK mode. After entering the data is exported to the examiner laser. And then we again confirm the area of the cone is corresponding to the same area of the keratoconus in the topography where we have planned previously. And this is the previous picture, as you see, is like we have a pyramid where we go and we can adjust and reduce the ablation of tissue by minimizing the fourth and fifth order abrasions can be ruled out in this case. And then we go give the planning and go ahead with the laser ablation. So this topo-guided laser treatment offers very promising results in keratoconus, especially who are intolerant to contact lenses. As you see, the laser ablation is being performed over the area of the cone, and following which we go ahead with the routine cross-linking. So this video is for TREC. Just a small change in TREC is we are not going to give a refractive correction in these patients because the corneal thickness is less. We are just going to ablate only the tip of the cone, around 20 microns of ablation. So here what we do is we measure the long axis as well as the short axis of the cone in the SWINT machine. In the cirrus topography. And after measuring the long axis and the short axis of the cone, the data is being exported again to the SWINT examiner laser platform. And then here, instead of we have to go in the PTK mode. And then instead of entering the manifest refraction and the targeted refraction, here we do a 50 micron ablation of the epithelium in addition to 20 microns ablation of the cone. So we just enter all those data, the keratometry values, and then we proceed to laser similar to the topo-guided PRK, where we ablate only the central part of the cone, which offers a very good optimization in cases with thinner corneas. So we shall go through a few case reports of
just 4 minutes, Shakti. I think you've crossed your time, no?
Yes, ma'am. I'll just finish off with this. This is a case of ectasia where you could see the pre and post-op topography, where you could see a very good regularization of the corneal surface following topo-guided PRK. And this, again, another patient with a very good regularization following topo-guided, as well as a very good improvement in the refractive best corrected visual acuity. And last, this is a case of TREC Why we went ahead with Trek? Because the corneal thickness was less in this patient, less than 450 microns. And this also led to a very symmetric regularization of the cornea. Thank you.
Thank you. Thank you, Shakti. That was a good summary. Dr. Rishi, I wanted to
Yeah.
ask.
Can I give one point to add to this? So, a nice presentation, Dr. Shakti. So, if you have a OCT which gives you the epithelial thickness maps, you can plan that in your Trek this thing. So, if you have the thinnest point having 39 or 38 microns, and you just want to ablate about 20 microns of stroma, you don't go 50 plus 20, but you actually adjust it according to that.
Okay.
And
Yeah.
another thing I wanted to ask you, Rishi, or anybody else in this group, even Rushad, if it is a
Yes, ma'am.
pediatric AC, and would you be absolutely no about doing a topo-guided PRK with cross-linking, or would you do it in some select cases?
Ma'am, in our setting, I would be a little bit cautious in pediatric TPRK. I haven't really done it because one is they are more aggressive for progression. The corneal thinning can be more later on. And we've in fact also seen even with conventional cross-linking, sometimes they continue to flatten, but they also continue to thin a lot more over a period of time.
Conventional cross-linking, yes, they would flatten. But if it is a smaller refractive error and a little irregular cornea, this is the only window you have to treat them. And I have not had, to my knowledge, of cases of topo-guided PRK with cross-linking which have gone into further ectasia. So if it is a small refractive error, if it's a larger refractive error, it doesn't make sense.
So by the time that pediatric cases develop ectasia or keratoconus, they are already past the amblyopic window. So I'm not worried about amblyopia. So from that point of view, I don't think I would like to do a laser for a pediatric case for many reasons, including possible medical legal reasons. So I think it's best to be a little conservative with kids. That's my opinion. And then try to manage with contact lenses or other measures.
Yes, definitely food for thought. Thanks a lot, Shakti. We go on to our next presenter, Dr. Dipti Mehta, who's a director and senior consultant cornea and refractive services at Kartik Nethralaya, Bangalore. And of course, we all know what a wonderful Keracon she gave us last year. So she's now going to talk on something different, tackling extreme hyperopia. So on to you, Dipti.
Thank you so much. Good evening, everyone, and congratulate ma'am for an excellent program. Really enjoy all the talks. So yes, this is a little different from the previous.
You know, your
talks,
voice
and
is cracking. Maybe your voice is cracking. Maybe you should switch
this.
video. Okay, let's see.
Is it still cracking?
No, not now. No.
So this was the topography of this 24-year-old corporate person who is our commonest client in Bangalore. He had this extreme hyperopia of 7.75, 2.5 cells, and very, very keen on refractive surgery because we know how thick these glasses can be. The AC depth was expected, very small eye, 2.67. So we would not want to squeeze in a ICL. And we know that excimer laser, most of the platforms give a maximum of 5 to 6 diopters. So what are we left with? Treat around 6 diopters and give him those cylindrical and spherical glasses, or we do a clear lens extraction, which for 24 may not be surgeon's or a patient's preference many a times. But that was the last resort. So on a combined decision, we planned something called as a consecutive double excimer laser ablation. Just go through his case. So there are 4 steps. We have been doing this for years now, and I'll just take you through planning of this gentleman here. So basically, we use the Alcon Wavelight 500 platform. And we are creating 2 treatments for him. The step 1 would be making a treatment 1, where we put in what the machine allows us maximum, that is 6 diopter of hyperopia, and we are debulking the entire cylinder in the treatment 1, that is 2.5. Simultaneously, we create a treatment 2 for the patient, which is the residual hyperopia, which is 1.75, and cylinder is usually debulked in the first treatment. Then obviously we are keeping the same optic zone and ablation zone. Hyperopia, try to keep as big as you can afford depending on the pachymetry. Regression is much lesser. And we do decentration for all our patients, myopic, hyperopic, unless you're doing a topo-guided, which we didn't do for him, where you can have an automatic visual access treatment. But for what we used was optimized treatment. So decentration is extremely important for hyperopic because they have a huge angle kappa. And if you can look at the green blinking light, which the patient is seeing, and the pupil, you'll see how nasally the visual axis is as compared to the pupil. So not only in double treatments, but we do this for all our patients and hyperopic more so. So this is of another patient, but just to show you how a significant angle kappa can be for hyperopics. So if you look at the 4 fixation lights or the fixation light of the patient, you see how decentered it's for the pupil. So it's extremely important when you're treating high hyperopia that you're treating bang on the visual axis. So over time, you actually get to know how much you have to decenter, and the pentacam with its XY sort of gives you a good idea. So decentration of 300 microns on X and 100 microns on Y was decided on him. And a lot of our machines give us this option to decenter our ablation. So the same decentration, ideally pupil is here, but we are treating the visual axis. I think this is one biggest reason why regression can be controlled. I'll tell you why. So if you are looking at a definition of a decentered ablation, you see that 0.5 mm is a mild decentration. And very often you have hyperopics with 0.4 or 0.5 kappa angle, and you're actually creating a mild decenter treatment just by not doing this decentration. So that was done for both the treatments. And the next variable which changes after treatment 1 and 2 is the keratometry. So for treatment 1, yes, you put the virgin corneal keratometry, but after debulking the 6 diopter and 2.5 cylinder, we know that the cornea is much steeper. So what is the K value that you want to put you for your consecutive treatment? So we did a series of retrograde analysis of around 30 cases of hyperopia. So I've just put in random 4 cases. And this is the virgin topography, and these were the treated powers. And once you are done with the treatment, this is how beautiful and steep these corneas become. And then you know the difference the treatment does to your K reading. So on analyzing this, we realized that a diopter of hyperopia would induce a 0.5 to 0.6 steepening of your cornea. So retrograde, we calculate it. So if you're doing a 6 and 2.5 debulking, then we steepen the cornea for the second treatment. So this is our assistant planning the first treatment, where we have put 6 2.5 with a 42.5 K readings for the first treatment. And we have calculated a 0.6 steepening, and we have put around 46.35 for our second treatment. And after this, it's like any other excimer laser ablation. You do treatment 1, and immediately you switch over to the treatment 2. So this is the same patient. We have analyzed a series of hyperopic and double treatment, and you see beautifully, this is a vision quality assessment by the OPD scan. You see a great improvement in the PSF. You see a very smooth topography, and this is the visual acuity, which improves. 2 concerns which we may think of high hyperopia is obviously are we inducing more of higher order aberration, and obviously the regression, which can be higher. So we have run these tests in most of our patients, and you would see the higher order aberration surprisingly is not too bad with a 3.5 mm pupil. The higher order aberration pre and post is not significantly changed and is just around 0.4 in this patient, and even his night vision and day vision is good. So this is again a patient who we recently saw back. This was her pre-topography and post-topography. We have probably operated her in 2014, and she came back sometime a year or 2 back. And you see that the change in the topography of 8 years is absolutely negligible, a 0.6 of difference. And same is shown even in her thickness maps. So many a times when we say regression post hyperopia, we are not tracking our topography. Many a times it may just be the latent hyperopia becoming manifest. So it's very important you do a good cycloplegic refraction and try to push as much as latent hyperopia. So the true topographic regression, actually when you're doing with today's flying spot with a larger zone, may not be as high as what we assume. So we have serial topographies of a lot of our hyperopic patients. where we have realized that many a times it's not the epithelial remodeling, but the latent which is becoming manifest, which is the reason for so-called this issue. So we have analyzed few years of cases. If I could summarize, maybe around 94 cases in the last few years of hyperopia, we have done a double treatment for almost 8.4% of our patients. So even if it is 6.75 or 7, we do go and treat back that 0.75 and 1, and we have had good results with that. So I would say this is certainly an out-of-a-box treatment. There are reasons why probably FDA approvals don't come for +6, but we should also look at the uniqueness of our Indian eyes. We are blessed with smaller pupils, so the higher order aberration may not be as bad when you are creating a hyperprolate cornea. We certainly have to avoid steeper corneas. We have usually done it on patients who have fatter corneas to start off with, so that we are not creating a very steep cornea post double hyperopic. And very important to look at the profession, lifestyle, personality. It does very well in office-based workers, homemakers, where they're not too much in the outdoors, and even when the pupil is little large, you're not creating any higher order aberration. And these are a set of patients who are unwilling for other modalities, which probably would be only clearance extraction. So I think with a good planning, it's just not creating 2 treatments. We should make sure the second treatment is bang on your first treatment. A little extra planning time. We have had excellent results with hyperopic eyes, and especially such extreme hyperopia where we have done double treatment. Thank you so much.
Yes, Dipti, that was an excellent presentation. Yes, regression would have been my constant concern in hyperopes. And as you say, with our large central zones, epithelial hyperplasia is something which is what we are need not be so worried about. If the curvature changes, gradient is not so much. But yes, I would have been quite cautious to do these treatments, and kudos to you. Rishi, you or Dr. Sonu Goyal, any one of you want to add anything on this before we go on to our next presentation?
That was an amazing presentation, Deepthi, and really nice big series of large hyperopic treatments and with such great results. So tell me, you are doing this angle kappa adjustment manually. Is it your machine doesn't automatically take it from your topography?
Yeah, so if you're using your wave light, if you're doing an optimized treatment, it doesn't. Only if you're doing a contour treatment where you use the vario, that it does. But some people use the vario and your contour thickness is much higher. So many times to tissue canvas, we do optimized treatment where it doesn't do automatic.
I just feel that in these hyperopes, probably I just feel that if you could do a cross-linking along with it, if at all you're going to treat such high hyperopes, probably that makes sense, because that might also address the regression and make these corneas a little more stable. Because I do believe in PRK extra having a role, and in high myopes or high hyperopes could be factored in. Rishi or Dr. Sonu, any thought on that?
So I think that's a wonderful.
Regression, none of the good studies have actually done a topographic regression. It's usually refraction regression, which can truly be you're not correcting your manifest astigmatism, manifest hyperopia. So we have done topography serial. We do a 1-month topo for every LASIK patient. So we have the data for years. That's been very useful for us to see, is it an axial change, or if it's a ciliary muscle change, or is it a true epithelial molding. So trust me, the amount of changes with whatever machine we have had, I'm sure all the other modalities are similar, is not really that bad if you're using a large optic zone and flying spot sort of a laser.
So thanks a lot, Deepti. We go on to our next speaker, Dr. Vivek Singh, who's a senior consultant cataract and refractive surgeon, and is now associated with Maxivision Super Specialty Hospitals at Hyderabad. And he is going to tell us something very quintessential, getting the right plane in Relax Smile, which is probably the solution to all the problems which are created in a smile surgery. On to you.
Thank you, ma'am. Thank you for having all of us here. And I would like to congratulate all the speakers for such wonderful talk, and also congratulate them for management of such wonderful cases. All the youngsters, seeing the presentations today would be, understanding that there's another presentation on smile, and they would not be too keen on planning their smile surgeries or would be refraining from planning smile surgeries because they've already seen so many complications. What I'm going to do here in the next 3 minutes is display a video here, which is done by one of the already smile performing surgeons, however, not too much of experience. All of us kind of remember our first smile. We do get jitters even nowadays, when you have certain extreme complications. I do remember my first smile as well. And it was kind of a beginner's luck to have a perfect, dissection. However, the second smile that I did was, it actually brought me down on the ground, and it had a cap tear and making the dissection quite difficult. So I have a similar case here. This is a young surgeon, like I said, trying to dissect the plane. As you can see, trying to dissect the anterior plane first, and then trying to have the posterior dissection. So easy to get into the posterior plane, and then not much of resistance between the two planes, and continues to dissect. One thing very commonly that we ask a beginner to keep talking to the patient, explain them what is happening, and just try to avoid movement of the eye. What exactly happens here when the surgeon is trying to dissect? Very commonly, the patient experiences some symptoms over there, some pain, and the patient moves the eye upwards. That results with the dissector inside the the plane, and that results in a cap tear over there. The surgeon is brave enough, goes again ahead inside to dissect the plane there, and is very confident. Something different happens here, and is a little worried. He's not able to find the posterior plane, or what he believed that he was dissecting the plane earlier was an anterior plane, but he's not able to find the posterior plane. Now you have a trouble here. There's a cap tear, and the surgeon very quickly realizes that the plane that he has dissected is the posterior plane. Now the lenticule is now stuck onto the cornea, with a tear in the cap as well. So it becomes really difficult. I was in the OPD. I'm trying to assess what exactly has happened, because I couldn't go to the video as well. I was just told there was a cap tear and there was a anterior plane dissection. I'm just trying to figure it out. I'm using the backside of the vexil just to have a proper support. And I try to, figure it out. I'm just, go and figure it out and find the same plane that was dissected earlier. So this is the same anterior plane. And getting into the posterior plane would be difficult here. The refractive error the refractive error, which was, I'm sorry about that. The refractive error was about around 4.5 diopters here. So now this was a chance to become a hero for the surgeon, to save the patient's eye, because the surgeon was an independent surgeon and not a trainee anymore. And secondly, hero for the patients to save the eye. Like Dr. Sahil presented in the video there, at such moments when you find yourself, you tend to, choose things which are not so or not probably is going to work in the favor of the patients. You tend to make a difficult choice over there. So I had a choice, to become a hero over here. The hero can be someone like a Iron Man, and be wise, make a planned decision, come back again stronger, and then execute your plan well. The plan would be to do a PRK, defer the surgery at this moment. But there would be a different kind of superhero there, just go ahead and continue with the surgery and try to be hero. No prize for guessing, I chose someone to be impulsive and try to do something extreme. And the idea was not to increase the cap tear further. And if I could achieve that and get the dissection plane, then the work would be done. Not realizing that what would happen midway. So I just continued. I couldn't get the dissection plane, but what happened, luckily for me, because of the thick lenticule, the lenticle got folded upon itself. So it was easier for me to just nudge the edge over there and continue peeling or pushing the entire lenticle towards one side. The second thing that I realized over a bit of dissection, that if I would do small movements that would just take care, or shorter movements, shorter rotatory movements that would increase the tear. However, making longer dissections or longer rotatory motions along the tangential plane would just help me peel the lenticular edges as well. Secondly, switching between the spatulated end as well as the sharp dissector helped me dissect wherever it was a little difficult. Eventually, I could just manage the taking care of the cap, the lenticule, and take it out right in time without increasing the cap tear. In retrospect, if I have to think, I would never prefer, I would want to be the Iron Man over here rather than the Hulk. And later on, just to avoid the epithelial ingrowth, we just debrided the epithelium and just placed a BCL. This was the second eye. The first eye had already gone really well. Day one, the patient enjoyed 6 parts vision, which improved to 6 later on. The surgeon also displayed the video to the patient, which showing where the patient had moved, and that resulted in a tear. So the acceptability was even better, and the patient could accept the result even better. Thank you so much.
Well done, Dr. Vivek. That was truly a challenging case, and with a cap tear, and it is very well done. Yes, Dr. Sonu, would you have done anything different?
So Vivek, congratulations. I think you ultimately proved to be an Iron Man. So just 2 quick pearls. The bells always leads to that kind of a cap tear. So left hand, as I said, has to be supported. You can use any of those forceps, limbs to just hold on. Secondly, you are always trying to fish underneath the torn cap. So actually, that doesn't give you, a steady kind of area to dissect. So what, at the later end you did was very nice. So taking a sharp dissector and going onto the inside where it has actually not been, the cap has not been torn. So you would have gone in and then you would have slowly, separated from underneath the margins of the side cuts. So I think that could have been, and then the technique that we have been discussing, the lenticoschisis. So this can also work well in these tricky situations. So, but all well that ends well. I think you did it very nicely, and putting a bandage contact lens at the end, I think that's also a great learning for all of us.
Thanks, Vivek. That was a nice example. So we go on to our next speaker, Dr. Abhinav Biala, who's again a consultant cataract and refractive services and from Amritsar Eye Care Center, Ghaziabad, right? I'm right? Dr.
Yes, that's right, ma'am.
Yeah. So now he's going to show us something in microkeratome LASIK, an incomplete pass, and how best he managed. So on to you.
Thank you so much, ma'am, for giving me the opportunity to present. I'll be ultra short in the interest of time. So I'll do the part.
There's suddenly a network issue with you. We're not able to hear you. Sometimes, it helps if you switch your video off. We are not able to hear you. Are you muted? Dr. Abhinav? Dr. Sonu, can you hear him?
Yes, ma'am.
No, we can't hear him. He's not audible.
Yeah. Dr. Abhinav, would you switch off your video and just show the surgical video? Sometimes it helps. He's been connected with us for so long, I don't know. He's talking, I think, no?
He is. I
think he's not unmuted.
Yeah, Dr. Abhinav, you need to unmute yourself. We heard him initially, no?
Yeah.
I think we should watch the video.
Purple color. Ma'am, I will call to.
Yeah, call him.
You go to others. Next talk, ma'am. I will call to.
He's showing his video, no? You can't. You will have to let him show the video.
If you want, I will stop it, ma'am. That's all.
Maybe we need to call him and let him know that he's not audible.
Okay.
I tried calling him, but he's not responding.
Oh. I think it is. Abhinav, we could not hear you. Somebody should call him and talk to him. We can go on to Dr. Syed. Please. Oh, it's an incomplete pass. Yes.
Am I audible?
Now you're audible, but now your video is not seen.
But we saw your video. Maybe you can just explain what happened.
Abhinav,
Right,
yes,
right.
Abhinav.
So the fellow had just stopped short, and you can see here it's an incomplete
Yes.
pass.
Yes.
But the lucky part was that I was lucky that the refractive error to be corrected was only one diopter, and there was no cylinder involved. So I went ahead with ablation, and the patient was 6-6 on the first post-operative day. So the message that I would like to drive home to the new trainees who are learning is that if you have a significant refractive error, and especially if the the hinge is very close to the pupil to the your ablation zone, not a good idea to go ahead with ablation, and better to postpone the procedure. Maybe 3 months later with a femtosecond LASIK or also a surface ablation.
Yeah, you can get.
Abhinav, did you reduce the optic zone here?
No. That's what so I was lucky that the refractive error was just one diopter. It was just at the edge of the optic zone that the hinge was lying. So I went ahead with ablation.
Yeah, but I have had an experience like you could end up having that the hinge getting hit, and that there would be a thin opacity there, and the patient would be left with a glare also. So
Right.
one, and maybe your hinge was quite far away, so you escaped.
Yeah. The only reason
Not
was
worth
that
it.
it was a very small refractive error, and that was the saving grace for the case.
So,
Yes.
Dr. Abhinav, I just want to ask, what was the reason for the incomplete flap?
The fellow got it was his first microkeratome LASIK, so he got scared, and he, instead of going all the way till the stop, he stopped just short of it.
Yeah.
Okay, but he could have continued after that, or maybe somebody else would have.
Correct. So it was so quick that he stopped, and he immediately pressed the reverse button, and by the time I could do anything, the microkeratome was off the ring.
Okay. That's what this is, the SBK, the Moria one. So
Correct.
very unlikely malfunction of the motorized blade would have happened. Most of the time, the problem for incomplete flap is the drape, the plastic drape can get in between, or your speculum
Right.
not wide enough. So this could be the reason. But maybe you could have reposited and continued. But since you already passed the visual axis, it was easy for you to continue with the laser ablation.
Right, ma'am.
Right?
Thanks, Dr. Abhinav. Thank you very much. We would have had more discussions in this because I have at least a couple of decades of microkeratome experience. But I think paucity of time, we should go on to our last speaker and give him justice. Thanks a lot. We have our last speaker, Dr. Syed Maz, who's a consultant LASIK and refractive surgery from the Center for Sight Group of Hospitals based at Hyderabad. And he's going to tell us about intraoperative lenticular tear management. So that's another challenging case to finish off with. So on to you, Dr. Syed.
So are you able to see my screen?
No.
So is my screen visible?
No, sir.
1 second. Can someone help me, please? Because when we started it, it was quite well seen. And I go to share.
Yeah. You have opened the presentation already, no?
Yeah.
Yes. There we are. Yes.
So Right. So I'll just go to the beginning. So this is right. This is a case of smile. I would dedicate it to my father's unit in the army, which was bash on regardless. So this is what I would be doing when I would be doing a surgery, not stop. And just see, I'm just separating the anterior lenticule. It's a -2 diopter correction. In the right side, I have just separated the posterior lenticule now. This is an unedited video. And now if I go on the left, I will be going on the anterior surface. So there will be no chance that I am going behind. Okay. So I have now completed almost the separation of the anterior lenticule. Now, once the anterior lenticular separation has been done, just watch carefully. I go and separate the posterior lenticule, but as I am separating, you can watch very clearly that there is a tear happening, which I have noticed. But then, as I said, bash on regardless. Don't stop, just go on and separate both the pieces without stopping, without taking your instrument out. So I've separated now the larger piece. Now you see I'm going and separating the this piece. Now you can see very clearly two broken pieces of the lenticule inside. Do not panic, just go in, give a tight grip, pull the one which is nearer out. Once you have removed this, you're very sure that the second piece is also there, and it's very well separated. Here, don't pull it like a Rexus motion, just peel it off and there it comes. So now even the second piece is out. So that's the end of the surgery. And I hope that I am not stopping you all from going to dinner. So that's the end of my presentation.
That was a nice brief surgery, well done. And I think some of the other measures for lenticule tear, and always ensure that your lenticule is adequately thick, that we decide to increase the thickness, and of course, your tips of dissection and ensuring it is completely dissected. And of course, if the worst case scenario, circle software to our rescue. Rishi,
Mark, what is the reason that they tore? Was it a very thin lenticule?
Thin lenticule.
Was it like a low
It was
refractive error?
-2 diopter sphere.
Okay.
Yeah, -2.
Cool.
Yeah.
Well managed.
Well
Very
managed.
nicely done. Yeah.
Dr. Sonu, you
Thank
want
you.
to add anything? I think he's left. So anyway, that was a very nice set of videos, all of you, dear friends. I mean, there's so much learning, and I'm sure many of the youngsters, if they latch on and watch these series of videos and the discussions which have followed, I'm sure there is a lot of learning, and every single video had a tip to convey. So thank you so much. Thanks, Dr. Sonu Goel. And though the last minute I somehow just moved away. Thanks, Rishi. Thanks, every single good speaker here for all the efforts which you have put, whether it's Dr. Ikeda or Maz or Rakshit or Natasha, every Tushar, every Rishad, every video was very nice. Thanks so much. Thank you.
Thank you.
Thank you. See you all soon.
Thank you, ma'am. Lovely webinar.
Yeah, very nice. Thanks, Dr. Sonu. You disappeared. We wanted your thought on the last video.
I just wanted to have a cup of coffee. So, but that was really very wonderful. Very, very nice presentations by all. I think everybody deserves congratulations.
Yes.
And above all, the way you conducted it was amazing.
Thank you. Thanks, Rishi, for
Good
staying
night.
to the end. Thanks a lot.
Thank you, ma'am. I learned a lot from this.
Thanks, Subhashini. Thanks so much.
From the beginning till
Thank
the
you,
end,
ma'am.
once I stayed put.
Thanks. Even Dipti, every video was nice. Thanks a lot. Good night, all of you.
Night.
Thank you.
Good night.
Thank you, everyone.
Good night.
Thank you, everyone. Good night.